A very warm good morning to one and all, dignitaries, teachers, and my dear friends. I, Eileen Kuriachin, from BPT 3rd year, warm-heartedly welcome you all to our workshop on an approach to comprehensive assessment and management of cerebral palsy, organized by the Department of Physical Medicine and Rehabilitation. I would like to invite our chief guest, Dr. Sudhir Sachdeva, to have a seat at the dais, who is to be escorted by Dr. Singh. Dr. Sudhir Sachdev is the President and Vice Chancellor of Mahatma Gandhi University of Medical Sciences and Technology. He has played an integral role in the growth of the institution right from its establishment. He has been instrumental in the formulation of new academic programs for the university, including the establishment of the Department of Physical Medicine and Rehabilitation, and also for starting the MD program in the subject. On the lighter side, he has great interest in art and culture, specifically music and singing. Professor Singh is the head of the Department of Physical Medicine and Rehabilitation at our very own Mahatma Gandhi Institute of Medical Sciences. He has also provided his services as the head of the department in All India Institute of Medical Sciences, New Delhi. I would like to welcome Professor R.C. Gupta, who is a learned professor of anesthesiology, but is also shouldering the big responsibility of managing our hospital in the capacity of medical superintendent. I would like to also welcome Dr. Munish Kakkar, professor and head of the Department of Pediatrics at Mahatma Gandhi University of Medical Sciences and Technology. He has been presented with the Fellowship Award by the Indian Academy of Pediatrics in 2020. He has also served as an executive board member of the IAP. We are very delighted to have you all here with us. Let us all give them a wide round of applause. To seek for the Almighty's blessings, I would now like to call upon Krishna Charan from BPT first year to guide us through Saraswati Vandana.
Ya kunde tushar har dhavala ya shubhrastu pata ya veena varadanta mantakara ya shweta padmasana या ब्रह्माच्युत शंकर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निश्चेषजाड्यापदा. शुक्लां ब्रह्म विचार सार परमेव आध्यां जगद्व्यापिनीं वीणा पुस्तकधारिणीं अभयदां जाड्याधकारापहाम्.
That was wonderful. We would like to felicitate our guests with our small tokens of appreciation. For that, I would like to call Meghal Gehlot and Ritunjaya Mishra from BPT second year. Firstly, to Dr. Sudhir Sachdev. To Dr. R.C. Gupta. To Dr. Munish Kakkar. Thank you. Thank you, sir. Now, I would like to invite Dr. Singh to extend his warm welcome to the audience.
My dear friends, we have started this program with the blessings of the Almighty to dispel the clouds of negligence or not having any knowledge, and to give us the brightness of the education and bless us. On the top we have the Almighty, and in this institution we have Professor Sudhir Sachdev to bless this institution to work hard right from the beginning and also start our department. And with the cooperation of all, PM&R is a multi-speciality discipline, and without having cooperation from all, we cannot function. And we are really blessed, and we welcome Professor Sachdev, Professor R.C. Anand, Professor Munish Kakkar, and you all for this wonderful program. And I am really grateful that you could come here and start. I welcome you all on behalf of the Department of Physical Medicine and Rehabilitation. Thank you so much.
Thank you, sir, for your greeting. I would now like to invite Dr. Munish Kakkar to address us for the event.
Honorable Vice Chancellor, Professor Sudhir Sachdev sir, respected Medical Superintendent R.C. Gupta sir, and respected U.C. Singh sir, I am thankful for your presence and motivate not only the students, faculty, and for the real cause of the humankind. As far as pediatrician, myself, my responsibilities are concerned, I am sure that this is the entity or chronic disorder in pediatric age group where we need very good team effort, and if team effort is really genuine and honest, I can tell you that we will not tell any patient that this disease is not going to be cured, or cure it in true terms might be difficult, but as far as patient is concerned or layman is concerned, we can solve the problem to great extent. So my advice to all the novice and the beginners in this field are that this disease really, if truly done, because I have seen so many patients who improved a lot, as sir told, that it should not be that mother should come and tell us that she wants to donate the organs of the child due to cerebral palsy. So that will be the failure of us. And I can assure you, if even we can motivate the parents, that will be the great service as far as cerebral palsy is concerned. So for that, we should have the good knowledge, we should have the good sessions as far as their managements are concerned. And if we are using our resources properly, and as far as our institute is concerned, we need that we should truly serve the cerebral palsy patient. So with that, I will like that you will benefited by the lot of sessions which are going to come after that. So thank you very much.
Thank you, sir, for your kind words. I would like to invite our honorable chief guest, Dr. Sudhir Sachdev, to impart some of his knowledge to us.
नमस्कार, वेरी गुड मॉर्निंग। बड़ा ही हर्ष का विषय है कि आज फिजिकल मेडिसिन एंड रिहेबिलिटेशन PM&R डिपार्टमेंट ने फिजियोथेरेपी वालों के साथ मिलकर के, पीडियाट्रिक्स वालों के साथ मिलकर के इस एक दिवसीय वर्कशॉप का आयोजन किया। और उससे भी अच्छी बात यह है कि इतने सारे विद्यार्थी आज यहाँ एकत्रित हैं, इकट्ठे हुए हैं। मैं आया, मैंने मुनीश कक्कड़ जी का भाषण भी सुना जो वो व्याख्यान दे रहे थे। आज हमारे बीच उपस्थित हैं परम आदरणीय डॉक्टर R.C. गुप्ता जी, मेडिकल सुपरिटेंडेंट, PM&R डिपार्टमेंट के विभागाध्यक्ष परम आदरणीय U. सिंह साहब, जो कि ऑल इंडिया इंस्टीट्यूट ऑफ मेडिकल साइंसेज से PM&R के हेड ऑफ द डिपार्टमेंट रिटायर हुए। जब ये बात चली, विश्वविद्यालय के चांसलर चेयरपर्सन डॉक्टर विकास चंद्र स्वर्णकार के साथ कि हम PMR डिपार्टमेंट को खोलें, तो उसके लिए फैकल्टी की जब आवश्यकता पड़ी तो हम पूरे हिंदुस्तान में जगह जगह पॉइंट आउट करने लगे कि अच्छी फैकल्टी कहाँ से मिल सकती है। तो ये संयोग था और ईश्वर की कृपा थी कि मेरा संपर्क परम आदरणीय सिंह साहब से हुआ। मैंने आपसे निवेदन किया इस विश्वविद्यालय के लिए, इस मेडिकल कॉलेज के लिए। पूर्व में भी मैं फैकल्टी से निवेदन कर उन्हें बुलाता रहा, लेकिन मुझे पहली बार लगा कि कोई व्यक्ति कितना सरल हो सकता है। मैंने विनम्र निवेदन किया और आपने उसको तत्काल स्वीकार कर लिया कि यदि आपकी मंशा एक नया विभाग बनाने की है, एक नया विभाग सेटल करने की है, तो मैं अपनी सेवाएं देने को तैयार हूँ। जबकि अपनी पारी, अपने जीवन की पारी एज ए PMR हेड सचिन तेंदुलकर की तरह से आप पूरी अच्छी तरह से खेल चुके थे, लेकिन उसके बावजूद भी आपके मन में इस बात का एक हर्ष था, एक प्रसन्नता थी कि यदि मैं अपने जीवन के इस उत्तरार्ध में एक नया डिपार्टमेंट किसी जगह एस्टैब्लिश कर सकता हूं, 2, 4, 5 साल लगेंगे, लेकिन आने वाले वर्षों में वो समाज की, विश्वविद्यालय की एक निधि होगी, एक अमूल्य संपदा बन जाएगी और आने वाले समय में उस विभाग से PMR के और रेजिडेंट्स, डॉक्टर्स निकलने लगेंगे। तो इससे अच्छा काम क्या हो सकता है। ये तो मेरे लिए भी एक प्रेरणा रही आपसे बात करके कि व्यक्ति को जीवन में कितना विनम्र और कितना सरल होना चाहिए। मैं आज सार्वजनिक मंच से आपके प्रति अपना हृदय से आभार व्यक्त करता हूँ। समय समय पर आपकी तरफ से हमें गाइडेंस मिलती रही। आप आए, आपने आकर के बताया कि किस तरीके से हम डिपार्टमेंट को ऑर्गेनाइज करें, PMR डिपार्टमेंट होता कैसा है, और अच्छे तरीके से सारा काम हुआ। और उसके बाद जब असेसमेंट हुआ, परमिशन मिली, डिपार्टमेंट बना, तो मुझे लगा कि ये ईश्वरीय कृपा ही है कि हमारा संपर्क सिंह साहब जैसे लर्नेड, विद्वत व्यक्ति से हुआ, जिनके गाइडेंस में, जिनके सानिध्य में ये विभाग खुल सका। तो ये जो आज आपने सेरेब्रल पाल्सी पर ये आज चर्चा रखी, ये सेरेब्रल पाल्सी एक विषय हो सकता है पीडियाट्रिक्स का, जो आपने इसको पकड़ा, लेकिन PMR में बेसिकली जो एक शब्द है वो बहुत महत्वपूर्ण है, वो है रिहेबिलिटेशन। जीवन के किसी भी क्षेत्र में रिहेबिलिटेशन का बड़ा महत्व है। कितना ही सद करके हम चलें, कितना ही सद करके, साध करके हम जीवन में आगे बढ़ने की चेष्टा करें, लेकिन पुनः पुनः जीवन में ऐसी अवस्थाएं, ऐसी कंडीशंस, ऐसी स्थितियां आती रहती हैं जन्म से लेकर के जीवन के आखिरी पड़ाव तक, कि जहां व्यक्ति को रिहेबिलिटेशन की आवश्यकता पड़ती है। और जब हम विज्ञान में, चिकित्सा विज्ञान में PMR की बात करते हैं, तो PMR स्पेसिफिकली ये फिजिकल मेडिसिन रिहेबिलिटेशन, ये मेडिकल कंडीशन से उनके रिहेबिलिटेशन की बात करता है। आने वाले वक्त का बड़ा ही चमकता हुआ विषय है। आप लोग अभी देखेंगे आने वाले वर्षों में कि किस तरीके से इस विषय की धूम मचती है और किस तरीके से विद्यार्थी इसमें आते हैं। इसी को फोरसाइट करके, इसी को आगे के लिए देखते हुए विश्वविद्यालय ने निर्णय लिया कि PMR डिपार्टमेंट खोला जाए। ये आने वाले वक्त की एक आवाज है, इसे पहचान के इसमें अच्छे तरीके से काम करेंगे। मुझे लगता है कि शायद ये पहली बार है कि अभी जो PG के अलॉटमेंट हो रहे हैं, तो रेजिडेंट्स अभी पहली बार अलॉट होंगे, तो रेजिडेंट्स आएंगे, डिपार्टमेंट और अच्छे तरीके से चलेगा। आदरणीय सिंह साहब की गाइडेंस में और अच्छी तरीके से तरक्की करेगा। मैं इस विभाग के लिए शुभकामनाएं देता हूं। मैंने पूर्व में भी कहा था कि आप विभाग शुरू करिए, मैंने सबसे रिक्वेस्ट भी की थी और सब लोग बड़ी मेहनत कर रहे हैं। मैं विशेष रूप से सोनू सिंह जी इस समय उपस्थित नहीं है, वो भी काफी डिलीजेंट, इंटेलिजेंट, डिवोटेड, समर्पित व्यक्ति हैं। मैं आज इस वर्कशॉप के अवसर पर आप सबको शुभकामनाएं देता हूं और प्रार्थना करता हूं ईश्वर से कि PMR विभाग जो है महात्मा गांधी का अपनी एक अलग पहचान बनाए और आने वाले समय में जिस प्रकार विश्वविद्यालय मेडिकल कॉलेज के माध्यम से समाज की सेवा में रत है, हम इस विभाग के माध्यम से भी अपने लक्ष्य, अपने गोल को प्राप्त करें। आज इस अवसर पर आपने मुझे यहाँ आने का मौका दिया, मैं आप सबके प्रति अपना आभार व्यक्त करता हूँ और आप सबको भी शुभकामनाएं देता हूँ कि जिस इच्छाओं को लेकर के अपनी और अपने परिवार की, अपने माता पिता की, आप इस मेडिकल कॉलेज में, इस विश्वविद्यालय में आए हैं, आपकी वो मनोकामनाएं पूर्ण हो और पूर्ण समर्पण के साथ आप एक अच्छा भविष्य बना सकें, अपने परिवार का, अपने कुल का नाम गौरवपूर्ण करें, राष्ट्र का नाम गौरवपूर्ण करें, विश्वविद्यालय को सम्मान दिलाएं। इन्हीं शुभकामनाओं के साथ थैंक यू वेरी मच, धन्यवाद।
Thank you, sir, for your words of wisdom. I would now like to invite Dr. R.C. Gupta to extend his words of appeal.
Respected sir, Professor Gupta sir, President Mahatma University, respected Professor Singh sir, Professor, and my dear faculty, I'm glad to be with you on this occasion. I was told to say a few words about both of things, but as a ritual, the information is very possible. Thank you. The cerebral palsy is it a problem? The family, is it a problem? But it can be, if you think in other way, it can be taken. Every problem, if thought properly, can be assessed. The parents of the especially able child thinks, why me? Why God has given this to me? When you come to the problem, it comes to mind, why me? Why only I have been selected for this? If you take it other way, when God makes so many models of human beings, millions and billions, some problems do occur in between. When somebody makes toys, some odd piece of the toy doesn't fit into, and that becomes special. God has to give it to somebody. So we should think God has chosen you to do service of this child. So you are special. You are a special parent. You are a special child. So rather than think yourself, it is the service of the God you are doing in the form of a child. If you think in this way, then everything becomes simple. Rather than cursing that child every day, every morning, every evening, then you appreciate it. So everything changes with attitude. The curse becomes a boon. So if care is taken in that way, most of the problems are. I know at least half a dozen families who have not only taken care of their own children, they have opened schools for the special children. In Jaipur also I know two of these institutions. I know one in Pune. So families have come out to the extent, they say if I am taking care of one child, rather I will take care of 50 children. They opened a school for these special children. So one should never think that this is a burden to us. We are lucky to be in this profession to help the children as well as to help the families in broad spectrum to the society. Now, I think the lectures will come and elaborate on these things. Every problem has got a cause, course, and then prevention. So of course, there are causes, there are prevention. The cerebral palsy starts before birth, during conception, during birth. So your aim is to advise the society, people, pregnant ladies, to take care of themselves, keep themselves away from the infections, have proper nutrition, avoid radiations, so that mutation will not take place. All these things, if you can guide them in advance, you can do a great service to the society. So you can prevent some of them. You can bring up some of them to a better understanding. And this is what I think about the cerebral palsy. To my job which was given to me.
डॉक्टर आरसी गुप्ता जी को धन्यवाद ज्ञापन के लिए कहा गया था, लेकिन मैं थोड़ा सचेत था कि धन्यवाद ज्ञापन हो उससे पहले मैं हमारे बीच आदरणीय डॉक्टर मृणाल जोशी उपस्थित हैं। आप एसएमएस मेडिकल कॉलेज पीएमआर के विभागाध्यक्ष हैं और आप हमारे बीच आज गेस्ट ऑफ ऑनर के रूप में पधारे हैं। मैं विश्वविद्यालय की तरफ से, मेडिकल कॉलेज की तरफ से, PM&R डिपार्टमेंट की तरफ से आपका स्वागत और अभिनंदन करता हूँ। आदरणीय यू सिंह साहब से अनुरोध करूंगा जो कि हेड ऑफ द डिपार्टमेंट में इस विभाग के, कि मैं मृणाल जोशी जी को फूलों का गुलदस्ता भेंट करके उनका स्वागत अभिनंदन करें। सोनू सिंह जी आपके साथ आइए। बड़े हर्ष की बात है, मुझे आपको देख के बड़ी प्रसन्नता हो रही है। मृणाल जी के पिताजी स्वर्गीय RC जोशी जी हमारे यहाँ रेडियोलॉजी डिपार्टमेंट के विभागाध्यक्ष रहे। मैं बात कर रहा हूँ सन 2002-2003 की। उस समय में रेडियोलॉजी में प्रोफेसर थे, मेरे गुरु भी रहे RC जोशी साहब। RC जोशी जी हमारे यहाँ इसी मेडिकल कॉलेज में विभागाध्यक्ष रहे। रेडियोलॉजी डिपार्टमेंट में, रेडियो डायग्नोसिस में आपकी माता जी श्रीमती नारायणी जोशी, डॉक्टर नारायणी जोशी फाउंडर फैकल्टी प्रोफेसर हेड्स में से थी हमारे यहाँ पैथोलॉजी डिपार्टमेंट में। तो आपको जब भी मैं देखता हूँ, कभी समाज में मिलता हूँ, आपके घर आता हूँ, कभी मुलाकात होती है, तो मुझे आपके माता पिता का योगदान स्मरण हो उठता है इस विश्वविद्यालय की तरक्की में। उसके लिए विशेष रूप से वो इस समय आपकी माता जी हमारे बीच नहीं है, पिताजी तो आपके चले गए, लेकिन हम उनको बड़े स्नेह से याद करते हैं। आप घर जाएं तो माता जी को कहिएगा कि मैंने आपके माता पिता के प्रति अपना आभार व्यक्त किया है, क्योंकि आरंभ के दिनों में जो उन्होंने योगदान दिया, ऐसे फैकल्टी के योगदान से विश्वविद्यालय आगे बढ़ता है, तो मैं उसके लिए आभार व्यक्त करता हूँ। और बारी आ जाती है धन्यवाद की, तो वो आपका काम है, आप ही को
On behalf of Mahatma Gandhi University of Medical Science and Technology and Mahatma Gandhi Medical College and Hospital, I am grateful to Dr. Joshi sir to come all the way from SMS and spare his time. I am thankful to Dr. Suresh Sadhya sir who has spared his valuable time from the university and to grace us for this occasion. And I am thankful to Dr. Yu Singh who has organized this wonderful workshop. And on the top of it, I am thankful to all of you who have come and to attend, and I am sure you will be benefited with this series of lectures and carry a positive message to the society. I am thankful to Dr. Munish Kakkar sir to this occasion, and I wish you all the best for the workshop. Please enjoy. Thank you very much.
Thank you for your delightful words. I would like to welcome Dr. Mrinal Joshi. He is the director of the world-renowned Rehabilitation and Research Center, SMS Jaipur, which is also known for the Jaipur foot. Now, let us move on with the event. I would like to invite Professor Munish Kakkar and Professor Yu Singh to chair the presentation program.
I am relatively new to the hospital, even though little over 1 year old in this institution. Prior to that, I was in AIMS, New Delhi. So I'll be just giving you an overview of cerebral palsy. I'll not be touching the details because that will be done by the learned speakers from after me. I tell you frankly, the very first impression which I had, probably that of a person with cerebral palsy, was my elder cousin, 5 years old, and he was all the time doing like this and having some odd kind of movements. He was still being carried in his mother's lap and we were running around. And we saw him walk somewhere close to 7 years, but we still didn't know what it was. And when he grew up, he was a clerk in a bank, but not doing much, just walking awkwardly and speaking awkwardly. That's what we know. So later on we know that probably he was the person with cerebral palsy. Even when I was doing MBBS or even junior residency, despite an orthopedics, I had not seen a patient so-called cerebral palsy. I had absolutely no idea what it was, even though we had a very small glimpse in our textbooks and rounds in pediatrics we were told. But the very first case of cerebral palsy, at least I saw during my post-graduation in physical medicine rehabilitation. Most of you must have been lucky to have seen it during your graduation days at least. As we know, the awareness amongst the doctors, unless they are directly dealing, is very poor. And the general public is absolutely negligible. Even though William John Little in 1862 described very well a few hundred cases of cerebral palsy. William John Little himself had equinovarus deformity, something like we see over here, even though he himself was not suffering from cerebral palsy, and it was known as a Little's disease for a long time. There have been efforts to include into the curriculum for the doctors what is disability and what is the legislation for the persons around the disability. So a little bit of effort is going into that with the PM&R departments coming in, but for the general public, awareness has been a little better with the coming in of the Equal Opportunities Act and finding out about access, right to education, and avoiding any discrimination, etc. One of the very good movies I recommend to the parents is My Left Foot, which was very good in finding out the remaining abilities of a person with cerebral palsy who had very bad spastic quadriceps, and he was lying on the floor all the time. In case you have seen the movie, you will realize that. And recently, this movie came in with Kalchi Koslim acting extremely well, but talking about some specific issues about socialization and sexuality in patients with cerebral palsy. So the awareness is coming up. Even though the incidence is pretty high, different books give different incidence, but you find that it is pretty high for 1,000 divers. You have about 1 to 4 cases. Some people even give higher. So learning what it is not something very specific like you have a test of say a particular virus or a particular bacteria and you hit the diagnosis. It's a syndrome of various symptoms which primarily affects the movement and the muscle tone. And in the muscle tone, specifically posture. So primarily we'll talk about the movement and posture, and with that movement coordination also comes along. So it's a disorder of movement and posture, either one way or having both the things included. How do these patients present? We'll be learning about the early diagnosis and other things. These are a few of the symptoms that will come. I'll not go into the detail, but the important thing that we have to tell is that no two persons having cerebral palsy are alike. They are all unique. One person with a similar kind of a topography, similar kind of spasticity and things like may be having different presentation compared to another person. So we have to have individualization of the assessment and the management suited to the person accordingly. Number of patients have difficulties with the walking, majority, and speech difficulties, hearing difficulties, specifically having specific infections during the early pregnancy. Visual defects, specifically squint and having visual cortex involvement, etc., are also not uncommon. The most common thing that we see is the inability to thrive. That means they fail to grow. Number of patients, as you see, is a very high percentage of patients who have IQ which is less than 70, almost more than half, and 25% have very low IQ, which may not make them live independently. So they have cognitive as well as learning impairments. Seizures are very common. They say as high as 75% in some studies, but at least 1/3 to half definitely have. Emotional and behavioral problems are again very, very common because they have disorder with their movements and they have other problems, eating difficulties, they have salivation, it's good for the teeth, they have to make it dry, you reroute the salivary duct, then they start to have more dental problems. Because they can't brush, they have clenched their teeth. Because of spasticity and other issues, the dental problems are also very much recognized. Spinal deformities because of awkward sitting, delayed sitting, gravity coming in, the posture or the tone coming in also leads on to kyphosis, scoliosis, etc. And because of the tonal variations, the deformities and contractures in the limbs and the joints are also seen very commonly, which becomes very difficult to manage. It's of course a neurological condition and occurs because of the either abnormal development of the brain, which is in a few cases, but mostly due to damage to the developing brain. Very commonly it occurs during birth or prior to birth, and sometimes during early infancy. The most important hallmark feature of cerebral palsy is that it's a non-progressive disorder. This thing is there with the growth. The person improves a little bit as he improves his intelligence or his growth or myelination, etc., but it's a non-progressive disorder. There are quite a few risk factors which are associated, commonly associated during the early pregnancy in the mother, like infections or certain toxins. That's why they say stop taking any drugs. Rubella infection, etc., in the early pregnancy, that's also there. In the infants, certain malformations or infections early in their infancy or during birth, and very commonly the blood flow, either hemorrhage or reduction of the blood flow, cord around the neck or long labor, etc., or injury, battered child, that also leads on to this. So there are quite a few risk factors in the mother, as you can read here, and I will simply rush through this. Amongst the causes during the labor, the very important cause is the delayed labor or the obstructed labor or cord around the neck. And in case the APGAR score is low, even 5 to 10 minutes after the birth, that also leads on to this. Jaundice is specifically related to having the ethitoid kind of cerebral palsy. In many patients, it becomes very difficult at times to find any cause at all. You cannot attribute any maternal or any birth cause or any other structural abnormality. There is hardly any correlation between the MR findings and the presentation. So it becomes enigmatic at times. We did a study in AIMS. We tried to study about 250 patients who were born at AIMS and tried to follow them until 5 years of life. And then we found the presentation commonly was a spastic cerebral palsy, more than 80% of the patients, and having quadriplegia. So spastic quadriplegia was a commonest thing, even though it is said to be 70 to 80%, but we found much more. But that was a closed study only at AIMS. And birth asphyxia in approximately a little over 1/4 of the patients. The common risk factors, you can read the paper in the Journal of Pediatrics. Common risk factors which we found, which were correlated to the development of cerebral palsy, were birth asphyxia, low birth weight, convulsions in the neonatal period, jaundice and neonatal infections, and the instrumented delivery, assisted delivery like the forceps or the vacuum, etc. So you can imagine, why do we put a forceps or a vacuum? Because labor is delayed, it is prolonged, and the antepartum hemorrhage, of course, is one of the important things. How do we find these patients? There are a few classifications. One is according to the tone. Majority are spastic. Then dyskinetic. Few are ataxic. Mixed variety is also not uncommon to see, having spasticity and acidosis common, or ataxia and other types common. Second type of classification is according to the body part involved. 1 limb, 2 limbs, 3 limbs, or 4 limbs. Many people try to call diplegia having main involvement in the lower extremity and hemiplegia main involvement of the upper extremity, but certain books say that in case all the 4 limbs are involved, of course each CP case is unique. You would like to call it better as quadriplegia with more involvement of the lower extremity, but some people like to call diplegia and hemiplegia as a separate terminology like this. Another thing which has an implication in the management is the severity. If we have a mild illness, most of the children grow out to be independent and don't require much of a treatment or an intervention. Moderate involvement are the ones who will definitely get better with our intervention, with therapeutic exercise, with the activities of daily living charting, or with the assisted devices, etc. So there the focus of management is very, very strong. So these are the people we have to work very hard. In this severe case, we can't bang our head against the wall and find nothing. The important thing here is how to look after the child and give the caregiver the know-how how to manage our children with a little bit of assistive devices, etc. So we have to see what is the involvement according to the severity, and accordingly we do the management. The modern day classification for assessment as well as for management is the gross motor functional classification. It definitely tells us about how much is the impairment and how much is the disability, what is the performance of the child, and it is based on the age range of the person and the type of activities the child can achieve. So we have a very good system for evaluation as well as for research purposes. And in case you see this photograph, starting on the top left is the level 1, which is more or less independent. That is mild category. And the level 2, the person needs a little bit of difficulty or impediment in the independence, but he is still able to manage. Third level is the person is able to do independent activities using some kind of an aid, either it can be an ambulatory aid or a wheelchair or something like that, but may have certain limitations in the next level, level 4. In the level 5, the child has to be given assistance, more or less, along with the aids, that the child is not able to perform even with mild assistance any activity independently. Of course, we have different scales according to the growth of the child. We have these 5 sets of ages where the activities are described, and it becomes very easy for us to find out what is the GMFCF score for the person without having much of a training in that. A very big question: how does it feel to have somebody with cerebral palsy at home? We know that it's a very, very awkward situation for the whole family. In case in the 80s, one Mr. Ali Bakr, who was a social kind of an activist on the media, he made a serial, Ek Ghar Aspas, in 1980s. Now, those days the television was very new and the serials were very new. The primary thing he was trying to make aware is that there is a child with retardation at home and he is never exposed outside his room, never socialized. And the children, other children, in addition to the person who was affected, they were also stigmatized, they were delineated from the society in the school, or sister of the child had difficulty finding friends. So this is a very big thing, that stigmatization occurs in the whole family, and many times at home the marriages are broken and the mother of the, along with the child, is discarded from the home, and they blame that it is a fault of the mother. So this is a very big social issue. But with rehabilitation intervention, with a holistic approach, we can do quite a bit, and the families can do a lot better with the child having some bit of independence gotten back. I tell you about an extreme case. It was a 5-year-old child who was brought, carried in the lap of the mother, very severely spastic, with having profound mental retardation. He was not even able to pull the neck at 5 years of age, and he came from Odisha. I was in Delhi at that time, and the mother very dutifully brought the child, and we gave the prognosis in the severe category, of course, not taken away the hope of the patient at all. We tried to carry on, but unfortunately 2 years later the condition was about the same, and the mother came and said, why can't you take the child, use his organs wherever it is needed, you can use the kidney, liver, and put in some other child, at least this child is useless for me. So that's where the extreme case comes and challenges us, and we didn't have any answer to such a thing. Many times, this is a very common question. Why me? Why our family is affected? Why my child is affected? So this is a very big question which comes, but we don't have any answer to that. But sometimes, some of you might have visited the Golden Temple, and you know the Golden Temple was the gold was put on the golden temple. It was originally a marble thing by the Sikh Maharaja Ranjit Singh. That you know. In case you have, maybe you don't know Punjabi, but in case you have tried to see at the entrance of this here. At the entrance there is a plaque which was put up by Maharaja Ranjit Singh here. Along with the inscription in Punjabi, it is written that the God was kind on the Maharaja to give this service of putting the gold on the golden temple. That the service was given, he didn't claim that he was the one who put gold, instead of saying this gold was put by Maharaja Ranjit Singh. It is said that God gave his blessings on Maharaja and made him do this. Learning from that, in case we see majority of some of the children, some of the parents of the cerebral palsy kids, they say that how do we cope up? They say that we believe ourselves to be special. In case nowadays, nomenclature for the persons with disability previously said disabled persons. Then they said persons with disability. Now we say Divyang Jan. Divyang means Bhagwan ke Jan. So these are special kids. So if we have something special and God has found us to be capable, only then He has given this kind of a service of upbringing such a children, because God had faith in us. This is the best coping that the parents can ever have. So this is how we believe we also can make or counsel the parents having the children, because we don't have any answers to why me. Now we have some bit of answer, yes, maybe because we are considered fit by the God to take care of His godly children. So this is a way we can counsel. That's it. Thank you very much.
So, good morning, everybody. It is my proud to be on the dais with Singh sir, who is the having the such vast experience in All India Institute of Medical Sciences, and I thoroughly enjoyed your presentation, sir.
Thank you, sir.
It was rather certain things I liked was the last few slides, where because this is a common question asked by the parents, and cerebral palsy is the one entity or disease where we have to cover from the 4 to 5 dimensions from all the angles to treat not only the child, but first we have to treat the family also, because it is very difficult in such condition, because any chronic disorder create lot of problems. I can tell you that because we are handling the patient every day, and this topic itself is very important as far as Mahatma Gandhi Medical College is concerned, because we are having a lot of patients from the Savai Madhopur, Karoli and these nearby areas where maternal and child health services are not as good as in other part of the state or like that, and we are having a lot of patients. And if really we are having some solid team efforts, I can tell you that our center might be the advanced center for the management of the cerebral palsy patients. So, as sir told that it is the disorder of the posture and movement due to non-progressive brain damage with sustained motor disability. So, certain things of my presentation might be the repetition of using because we are not seeing our presentation. But on other hand, it might be useful for the students that they can come to know that what things are repeated again and again means that might be having some more significance and they can focus on that. So, cerebral palsy patient, why they come in our hospital? Because you will see this is the only chronic disorder in pediatric age group where he might be having bag full of the reports, MRI reports, and lot of investigations and hopeless, and they are searching in the doctor that he might be having some ray of hope. And if they are coming, either they are having that I will give them the belief that your child will be okay after 2 months. That might be one reason, or other reason is that they are having certain complications for which they consulted our hospital, they need tertiary care. and our center is having this new pediatric advanced care unit, dialysis unit also, and we provide for our serious patients in ICU. So type of this slide I found, this is from some other presentation, what regions are involved and how the cerebral palsy presents. So you can see hemiplegic and diplegic. Hemiplegic, one hemisphere is involved, although colors are not coded correctly. One hemisphere there, some reddish color is there. This area you will find some colors. So this hemisphere is involved only, and in this diplegic child, both hemispheres are involved, but to the this sulcus, and then this quadriplegic, all cerebral cortex and large area is involved. And in dystonic and athetoid type, you can see this basal ganglia part is involved, and in this ataxic child, you will feel that cerebellar involvements are there. Although they are having a lot of multiple problems are there. So common medical problems in early CP. CP is most common and costly form of the chronic motor disability that begins in childhood. So I will continue my presentation because just I am going to start. अभी नहीं आगे जस्ट वॉशरूम जाके अच्छा अच्छा ठीक so means in means Western world they consider it a very costly affair. Reason is that they are concerned about, and to my surprise, really their children are doing. You will find that a lot of cerebral palsy patients on wheelchair are there at outings also. They are having the concept of respite care. Respite care means parents are looking after, like with God has given them the opportunity to look after the cerebral palsy patient, but still they need some means time for their outings, and they are having one group, common group, where the other parents of the means cerebral palsy patient are looking after their child, and when they are going out, they are looking after the child. So these type of care they ensure that their child should get, and improvement is also tremendous. I can tell you that their children who are moderate to severe cerebral please. Thank you. Sir, with your permission, can I continue?
Yes, please.
Sir, yeah, we can start inauguration.
No, please continue.
Thank you, sir. Thank you. So, prevalence of cerebral palsy has increased as a result of survival of very. Nowadays, you see how much advanced our medical services are there, but still cerebral palsy patients are increasing. Reason is that now we are able to give good quality of care. Dr. Saurabh Singh is here from Department of Neurology. That here they are saving the child of 500-600 gram baby, newborn baby. So if they are saving so much preterms, so sometimes outcome is not that good. Later on they are having a lot of comorbidity, and cerebral palsy is one of them. So motor handicap may be the least of child's health. Also, you will see that they are having so many problems that sometimes they forget about the cerebral palsy and they are focused about chronic constipation, pneumonia, some other problems like that. So incidence, this is the data from the All India Institute of Medical Sciences, that mental retardation is present in 50 to 75%. When I was doing my residency, we were never writing cerebral palsy alone, we were writing CPMR, cerebral palsy mental retardation. The reason was that most of them were having some input of the or some element of the intellectual disability. Seizures are also quite common, 25 to 33%. Hearing and speech defects, 15 to 20%. And behavioral problems are also quite common, like they are hyperkinetic, attention deficit, aggressiveness, and some abnormal movements and behaviors are there. Then problem associated with, they might, if because of prematurity, they are cerebral palsy problems of the prematurity itself might be the early presentation in these cases, like small stature, osteopenia, chronic lung disease, bronchopulmonary dysplasia, retinopathy of prematurity, growth retardation, patent ductus arteriosus, and hydrocephalus. These are the means associations of the prematurity. So that might be persisting in our cerebral palsy. If we are treating simultaneously, outcome might be improved in a great way. Reason is that whatever cerebral palsy comes, we forget about the other system, we never examine the child properly, and with one problem, two other problems are going on, and child's outcome is not that good what it should be. Mobility and other problems, kyphoscoliosis, hip subluxations, contracture. Contracture is really troublesome problem, I can tell you, and most of those children are having contractures. If we can handle this entity properly, at least there means movement and mobility part and lot of other problems which are going on can be handled. This is the pes valgus. Why I put this slide? Because it was not my area, but in our neck inspection, Dr. Sindhu asked specifically to our physiotherapy and occupational therapy students what is pes valgus, what is echinovirus. So they were unable to answer. My sincere advice to all you people are the first, kindly read some basic things of the our means whatever course we have opted already. So you will enjoy the reading and you will enjoy your course as well. This is a echinovirus deformity. This is the sir told you the classification of the functional means things. This is a level 1 is child can do all the activity outdoor as well as indoor. Type 2, indoor he is able to do all the activities of the household, but outdoor he needs some assistance of the crutches and all that. Type 3 he needs some support indoor as well as outdoor. Type 4 on wheelchair, and type 5 he need even further on wheelchair also he is unable to do the things. So this is my simple thing and little bit detailed sir told using this sir told already. Feeding and nutrition problems are very common which we pediatricians are looking after. Sucking, swallowing disability, sometimes we are keeping with the nasogastric tube in early days. Sometimes we need to do the gastrostomy to give the nutrition and other part properly. They might be having gastroesophageal reflux. Aspirations are quite common for which they are admitted in ICU. Failure to thrive, dental problem, teething problem, anemia, rickets, vitamin deficiency, electrolyte imbalance, these are the secondary due to ongoing cerebral palsy problem. Other problem like urinary incontinence, constipation is a big problem in the children and sometimes we have to admit just for the constipation to the children. Chest infections are quite common due to ongoing aspirations. Pressure sores are there. Sometimes bad sores might be there. Menstrual problems in adolescent female child is another area which we need to cater and we have to look after. These are some of the neurological associations. I will not go in detail, that time will not permit. So ocular defects in CP are quite common. As sir told that it is 50 to 20%, but if we are including the smaller things like nystagmus and some non-vision problems also, then even they might be having a lot of things. Nystagmus is there, and then strabismus is there. Cataract is quite common if they are having cerebral palsy due to rubella infection. Cortical blindness if they are having quadriplegia with lot of involvement of the cerebral cortex. Myopia, retrolental fibroplasia, retinopathy, and if optic atrophy, we need thorough eye examination. And in summary, I would like to tell that cerebral palsy, it is some remark by the parents of the cerebral palsy patient. Cerebral palsy is not so rare. It is caused by brain damage. There are different kinds. There are varying degrees. It messes with the muscle big and small. It can make you tight or loose, means it could be hypertonic or hypertonic. It can be different every day. Every day problems might be different, challenges might be different. There is no cure. Means we have to not think that it could not be cured. If mild and moderate are there, we can reach up to the level of the cure. It does not disable your personality, and because if mental retardation is there, usually chances are that your personality might be intact, and you should not feel bad for people with cerebral palsy. Thank you.
Since we already had 2 lectures before we started this inaugural function, may I now request Professor Jitendra Gupta now to come to the dais and give his presentation of infant newborn management and safety.
Good morning to all respected colleagues, students. I will briefly describe management of cerebral palsy. Cerebral palsy is not a single disease, it is not a single entity to treat by a single person or single doctor. It is a multidisciplinary approach. It is a team management. Even I am a pediatrician. Pediatrician is one of the member of that team that manages the patient of cerebral palsy. So, what is our goal? Cerebral palsy patients are normally deprived. They are not properly developed. So, our aim of cerebral palsy is to promote the child, to promote the proper development of that child, so that he can live a normal life in a normal society, to promote the proper development so that he can live a normal life as much as possible with independency. That is our main goal. As I described, management of cerebral palsy is a teamwork along with pediatricians, other persons like Sir, PM&R department, occupational therapist, physiotherapist, pediatric neurologist, psychiatrist, ENT specialist, audiologist, ophthalmologist, and in between these parents of families also an important role. So this is a group practice, or this is a group approach, combined group approach to all that persons that involved in the management of cerebral palsy. These are our lines of management. Normally, what problems occur in a cerebral palsy? As I described, 3-4%, about 75 to 85% patient having spasticity. So commonest cerebral palsy is spastic type of cerebral palsy. So treatment of spasticity in our pediatric age group is very important, because most of the child comes with, parents comes with OPD. If my child is unable to move that limb, his limb is so tight, we are unable to change the huggies, we are unable to change the posture of child. When we try to change the posture, child become cry, and child gives appearance of tightness or unable to do an activity at a particular age. Any age the child have a doing some activity and child is not doing well. So normally child comes with spasticity is one of the commonest problem in cerebral palsy. Along with spasticity, other conditions like, as I described, about 30% of patients having somehow mental retardation along with seizure. So resistant seizure, epilepsy is another common problem that is also in front of us, and to be treated properly so that somehow we improve the quality of life of that child. Along with that, there is a appropriate school placements, because normally child are neglected. They are not getting proper education, because in India the schools are not so developed for these types of childs. So we start for proper school placement of that child. Along with, there is a young stimulation program, young infant stimulation program. They are describing the slide below 6 months of age, so that the proper stimulation of that child develop, so that child grows well. And lastly, we associated some deformity. In long term, these child develop spasticity, spasm, orthopedics problem, some surgical problem. They should also come in front, and we treat accordingly. The first we describe treatment of spasticity, because 2/3 of patients of cerebral palsy having spastic cerebral palsy. Child most of comes with child having tightness, child is hard, unable to move limbs. So these is, and in spasticity, baclofen is one of the most promising medicines. Now we OPD we use. It is a GABA agonist. It decreases the excitatory activity of neurons. Somehow decrease the tone. Initially, we are using oral dose, but now a time in severe spastic conditions where oral dose is insufficient, then intrathecal baclofen is also used. Normally, we use oral dose 0.222 mg per kg per day in 2-3 divided doses. Dose should be titrated accordingly because if you give the more dose, child become dull and child will hypotonic. You balance the drug in a that dose, if child decrease somehow spasticity so that you can do any maneuver. Because normally physiotherapists advise physiotherapy for spasticity. But before starting physiotherapy, you slightly decrease the tone of that child. Otherwise, you are unable to move the limb. If child having some spastic diplegia and you advise 4 or 5 manuals to relieve the spastic diplegia. But in the spastic there is an adductor hypertonia. The adductor tone is so high. If you move the limbs, child become cry, or in some conditions you may rupture the muscles or bone. So in these conditions you give some medicines to slightly relax the baby. So one of the commonest medicine uses baclofen. Other drugs are like benzodiazepine, diazepam, midazolam, and some other dantrolene, clinidine. These are less likely used. The commonest is baclofen, and second common is diazepam, a dose of 0.03 to 1.2 mg per kg. According to body weight, and dose should be titrated accordingly because dose is different from some other to some other babies. Some baby require low dose and some baby require high dose. But we adjust the dose accordingly that child can move limbs or we can prevent further damage during exercise or physiotherapy or occupational therapy that is we are doing. Along with medical management, there are other manuals that described in further sessions by physiotherapists or some physiotherapy manuals and orthopedic manuals to relieve some extent the spasm so that child can move. In physiotherapy, we can further improve the motor functions. We improve the strengthening of muscle so that by physiotherapy the muscles power improve so that child can move limb properly. In various orthopedic procedures, manuals are also required that can improve in which their tendon transfer, serial plastering of limbs, some bone surgery, that osteotomy or osteodesis to increase movement at a proper joint. Because in severe spasticity, the movements or joints are so fixed, they are unable to move, and till joints are moved, child unable to move properly, or child can walk, child can crawl. If child's joints are not so simple, if child joints are so stiff, so tight, so these manuals are used to somehow relieve the spasm by some medical management, If there is some extent, along with medical management, some physiotherapy manuals or some orthopedic procedures or some orthopedic manual to relieve the spasm. And somehow there is a selective dosal rhizotomy. It is some neurosurgical procedure. The lumbosacral spine, we are injecting some medicine to relieve the severe spasm in a treatment of. Along with spasticity, there are other problems that also occurs in these babies. Like these babies having more chances of gastric esophageal reflux. They are repeated reflux. They have chances of repeated aspiration pneumonia. For this, you can give some prokinetic drugs like metoclopramide, ranitidine, so that reflux some extent decrease to prevent further aspiration, pneumonia or some other medical problems. Other problems that is more common is the excessive salivation. About 30% of spastic baby having excessive salivation. Parents complaining of continuous drooling of saliva. That may be due to pseudobulbar palsy or some other incoordination of deglutination. For this, we give symptomatically some atopy-like derivatives like glycopyrrolate. Normally, it is not a good medicine, but in some conditions we can use other procedure, like in some conditions if there is excessive salivation, then botulinum injection can be injected in salivary glands to some extent decrease. Otherwise, we train the parents to prevent, because excessive salivation somehow can lead to aspiration pneumonia and further. As I described, constipation. Constipation is also a big problem because these child are hypertonic. Mostly child are spastic. The muscles movement are not so regular, synchronized. The bowel movement are slightly always hampered. Do you give proper diet, proper nutrition, and maybe require some laxative, but diet should be adjusted accordingly so that this motion frequency can be managed. Because as I described, many child admitted in hospital only for this condition. A child having excessive salivation and constipation, not part the motion for last 10 days, 15 days, and child come with a condition of subacute intestinal obstruction. And we manually decompress. Other problems are like child having associated problems. Child come with athetosis or chorea or abnormal movements. Child having proximal movements, abnormal movement, and parents are unable to control the limbs. In this, we can give some medicines like tetrabenzene, reserpine, and these medicines are normally given to treat dystonias, athetosis, and for dystonia, levodopa is a very good medicine, and other medicine using trixaphenidyl. So these drugs are used for associated abnormal movements. Like child maybe comes with athetosis, chorea, or dystonia. Somehow I described shortly on botulinum toxin. Botulinum toxin used in extreme conditions. Normally, PM&R departments and some other departments use these injections, but there is extreme spasticity. In these conditions, it is a toxin derived from Clostridium botulinum bacteria. It blocks acetylcholinesterase, and we give multiple injections on the affected muscles to relieve the contractions. In extreme conditions, botulinum toxin injection can be given by expertise, mostly in PM&R departments or another department normally used for extreme spasticity. Botulinum toxins are used. Along with treatment of spasticity, there are surgical problems normally occurs because if child is long-standing cerebral palsy, they develop multiple problems. They develop multiple fixed deformities, and you are treated mostly after 4-year phase. Before this, there are more chances of recurrence of these problems, and this is individualized. And surgical problems are mainly so problematic in these patients. Along with surgical problem in long-standing cases of cerebral palsy or neglected cases of cerebral palsy. Their long-standing patients develop orthopedic problems, and along with this, their proper orthopedic management is very important. It means there is a contracture. A long-standing patient develop contractures of muscles, contractures of tendon Achilles, adductors, hamstrings, and these contractures cause unable to move the limb, even child unable to try to do any process. If child unable to try to walk, unable to try to crawl, due to this contracture, mostly these occur due to mostly neglected. If you start interventions as early as possible, these contractures should be relieved, and these contractures can be managed by help of physiotherapy department or with the help of other specialty. In long-standing procedure, they develop contractures and they require multiple procedures, like these are orthopedic procedures, in this tendon transfer, tendon lengthening. These procedures are done to relieve somehow contractures, along with botulinum injection can be given also. Along with long-standing patient develop scoliosis, normally because child remain all time in bed, unable to move properly. His scoliosis develop so frequently. For this, proper braces, jackets are required to prevent further progression of scoliosis, or in some extreme cases there is a open fixation or treatment procedure are also advised. In continuation of orthopedic procedure, the hip dislocation, about 30 to 40% cases of spastic cerebral palsy having spastic diplegia. Now at time spastic diplegia is so increasing because there are premature babies are survival more. In most premature survival babies below 1 year of 1 kg of weight, their chances to develop spastic diplegia. In spastic diplegia, in long-standing defaulter cases, there is a hip dislocation. It is one of the common problems. For prevention of hip dislocation, you do some maneuvers. There are orthopedic maneuvers like adductor tenotomy, obturator neurectomy, derotation osteotomy, and in extreme cases, you can do correction by open removal of head of femur or open reduction for proper treatment of hip dislocation. And for upper limb, there is a hand surgery, some bracing, testing, or dynamic bracing procedure also required for upper limb problems. Along with now time, variety of new things are occur. These are instrumented gait analysis. There is a child's gait is analyzed by some process, and we program accordingly how to manage the child's gait, so that in future time he can walk properly, or some single event multi-level surgery or orthopedic selective spasticity control surgery. It's a group of surgical procedure by orthopedic surgeons or some surgeons to reduce spasticity and for proper movement of that joint, so that child can walk, child can crawl, or child can move properly. There are some neurosurgical procedure also done to relieve some extent the spasm or other movements. For this, as I described, baclofen can be given intrathecal in lumbosacral region. It decreases the side effect of oral dose, because if you increase the oral dose of baclofen, it does the child become hypotonic. It remove the systemic effect of baclofen. It directly acts on nerve fibers, on lumbosacral region, and it remains permanent. So it's a very good modality to relieve spasm of spastic diplegia or lower limb. Other procedure like selective dorsal rhizotomy is also procedure to, it is also one type of good procedure by lumbosacral region to relieve the spasm. And in orthotoid or dyskinetic of cerebral palsy, mostly your thalamus or extrapyramidal system is involved. There is some procedure like osteotactic thalamotomy. This is a neurosurgical procedure to decrease some extent the extreme type of orthotoid CP, because orthotoid CP is one of the worst type of CP. Parents are so much frustrated that child's movement is not controlled by anything, by any medicines. In extreme resistant cases, some CNS neurosurgical procedures are done to somehow relieve this kinetic type of cerebral palsy. Along with there are some other associated type problems, normally others. Medically, we should treat it. In this feeding problem, because this child having somehow pseudobulbar palsy or incoordination of deglutition or incoordination of deglutition or movement of, the child is unable to swallow properly, and he further regurgitate. If you give some food, some liquid, somehow is swallowed, somehow regurgitate or can be aspirate. So treatment of this is very important, because feeding is an important thing. If child is unable to feed properly, it definitely develop multinutritional deficiency along with other crippling problem of cerebral palsy. Cerebral palsy problem get it treated, but you should give proper nourishment. For nourishment, there is a feeding problem normally comes very. So for this, in gastroesophageal reflux is so common, and for due to this there is a further aspiration pneumonia, and that aspiration pneumonia lead to admit recurrence in a hospital. There are more chances. For this, you give proper feeding. You advise the parents how to feed. Feed in a upright position before and after feed to thicken the feed. You give some medicines like prokinetics, H2 receptor blockers, or some anti-reflux medicines. If child is unable to feed, swallow, then you give feed by nasogastric tube. In extreme condition, there is gastrostomy tube placement by a pediatric surgeon for product placement of nutrition, because nutrition supplement is a very important thing along with your other management of spasticity, convulsion, any other thing. Along with this, their nutritional rehabilitation is a very important thing. As I described constipation. Constipation is very common. Further diet, proper diet, hydration, and lactulose or any laxative can be given properly to treat constipation. Incontinence is also common. In some child, give proper toilet training to child, toilet training to parents, how to do proper toilet training in a timely manner every 2 or 3 hourly, so that minimum spoiling, minimal problems. In extreme condition, you can advise some other procedure to minimal spoiling or minimal. And long standing, if child remain in bed, there chances of osteopenia. Bone become weak. For proper supplement of calcium, vitamin D, bisphonate or other therapy, hydrotherapy, increase the density of bone. Otherwise, in long standing, these weak bone become fractured, and these fractured bone are difficult to heal, because if this bone is osteopenia. So proper treatment of osteopenia is also important to further damage or the bone. Along with this, epilepsy is also common. 30% of child having convulsion or epilepsy. Some may require one medicine, some may require 1, 2 or 3 medicines. It is individualized to child. but our aim to minimize or control the epilepsy, because it further damages the existing brain. जो उसका brain है, it further damages. If the repeated episode of epilepsy occurs, it further damages the brain. So we proper control the epilepsy by medicine 1, 2, 3, 4 on the basis of type of epilepsy, or we give some medicines. If child having difficulty in hearing, you advise send to some ENT surgeon, audiologist for proper hearing assessment. If child require hearing aid, you can give advise child to a proper hearing aid. If child having some visual problem, child may squint, diplopia, or chances of optic atrophy, you send the child to a proper eye specialist for proper. If child having sublearning disabilities, child is hyperkinetic, you send the child to the child psychiatrist or occupational therapist for a management of that part. Now time, there are newer development of treatment. There is not so much advancement in the development of treatment, because in India we are not still following the conventional management. Along with conventional management, these are newer, like now time, stem cell therapy can be proposed treatment. There is no definite role of this. So we are starting from conventional treatment that is more important in a management of cerebral palsy. And lastly, rehabilitation. Rehabilitation as such described, rehabilitation is a part of PM&R department. So rehabilitation is very important with management. Rehabilitation management is something intermingled for proper parental counseling, for social awareness, or some vocational support. These all involved in the rehabilitation. And the screening of cerebral palsy patients also important on the basis of. Then these points comes with lack of alertness, child comes with, or mother comes with complaint of lack of alertness, lack of wholeness of neck hold नहीं कर पा रहा है, unable to move timely, unable to vocalize, take cortical thumbing more than 8 weeks, child not recognize mother up to age of 3 or 4 months, and no social smile up to 2 or 3 months. If these points comes, these are comes, we think we do some problem with child, and we also think is planning for screening of that child in view of cerebral palsy. Cerebral palsy, normally we are not denote cerebral palsy up to the age of 2 years. Normally we are not labeling the child, but we can say this child may be chances to be cerebral palsy in an early time. But definitely we say cerebral palsy mostly after 2 years of age, because our brain grow up to age of 2. Mostly we mind in 90% of our brain grow up to age of 2 years. And after 2 years, we definitely say child is a cerebral palsy. Till 2 years, we say child is chances to become a cerebral palsy on the basis of this. If child is unable to lack of alertness or reduce consciously, delayed social smile, then persistent of primitive reflex or cortical thumbing is persist more than 8 weeks, then we suspect the child may be chances of entering cerebral palsy in the future. Now time there is a young infant stimulation program, normally for less than 6 months of age. A stimulation program stimulate if child having comes, or as I described, mother comes ki my child is not responding, my child is not social smiling, not recognizing me, child is not holding the neck properly, then we suspect and we start these stimulation program. For visual stimulation, we give child to hold a toy. So child tries to fix that vision for a proper toy. Or for hearing stimulation, we talk the child, give a singer or play a music, so that child can move his head towards the voice, so that we can recognize the child hear properly or not properly. For tactile stimulation, we touch the baby, we rub the baby, we gently stimulate the baby for tactile stimulation. For sensory stimulation, we also rub the baby or body or scalp gently. So with tactile or sense stimulate the baby. And for speech stimulation, we talk to the child, so that child can stimulate. So these are young stimulation program normally done in 6 months of age. And lastly, we make the life of child easy. That is one of the important. So we create the devices for proper development of child. Devices for feeding, devices for grooming. These are some devices. Normally we are using these devices, but these devices sometimes specialized for that type of such child. Like devices for feeding, they are adapted utensils, they are long straws, adapted cups, or devices for grooming, brushes with long handles. These are adapted dresses having zip, the child can move, open these dresses, or devices for bathing like long handle sponges. These are very good thing to make the life easy of that child. So these are important thing for one of the quality of life, one you can say. So these devices can be very well available in market, and they can adjusted for child. And lastly, family support is very important, because this is a group management of a persons or doctors. Along with group, family is an important part. Family and teachers. Teachers, school teachers or home teachers, if they groom the child properly, teach the child and properly handle the child. And I described to 1/3 of patients having normal IQ. These are not all are mental retard. They can live a normal life, they can enjoy life, they can do all type of work with some assistance. And outcome is that 90% of patients can reach adolescent age if they are treated properly, and life expectancy is only severe affected child. Otherwise, they can end life. And lastly, is a target milestone. These are milestones. When we suspect, earliest to suspect, as I described, we are labeling the CP mostly after 2 years of age. But if your child having these delayed target milestone, then always you think the child is in chances of become cerebral palsy in future, like lack of social smile by the age of 2 months, absence of stable head control by 4 months, inability to recognize the mother by 6 months, inability to sit when pulled to sit by 6 months, lack of creeping by 9 months, inability to walk by 1.5 years, and absence of syllabic privilege. These are target milestones, always very important. This point us to the child may become development of CP in a future. And lastly, prevention. Prevention by good care, good prevention of birth asphyxia, prevention of prematurity, good supplement to mother, magnesium sulfate tocolysis in premature baby deliveries. Thank you.
So my previous speaker has practically covered everything. So let's see. Feel free to ask questions, okay? So nobody can cover the whole management in one slideshow. So if we go through the history, it was Shakespeare's The Tragedy of King Richard III, where they had described a cerebral palsy child. And Shakespeare writes, the rank curtail of this far proportion, cheated of feature by dissembling nature, deformed, unfinished, sent before my time into this breathing world, scars half made up, and so lamely and unfashionable. So, probably a preterm delivery with deformities, having growth retardation. So this was described in Shakespeare's. I won't go into it because part of them has been covered by him. So I'll come to the point. The first thing that we have to understand is what is cerebral palsy. And we are still trying to find out different definitions of cerebral palsy and spasticity, how to define it. Because the last definition that came out was in 2007, which is not too far back. And the spasticity is recently defined again in 2021. So as we are evolving, more and more science and technology and research is happening, so we are exploring the new definition. So it says it describes a group of permanent disorders of the development of movement and posture causing activity limitation that are attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. And the motor disorders of cerebral palsy are often accompanied by disturbance of sensation, perception, cognition, communication, behavior, by epilepsy and by secondary musculoskeletal problem. So basically, it's an umbrella term. So the umbrella term for all non-progressive brain problems. I'll just skip this slide because it's a lot of other things. So basically, when we are looking at cerebral palsy, we try to define them in different major categories, broad categories. It can be a spastic bilateral CP, it can be a spastic unilateral, it can be a dyskinetic. Pointer, right? Okay, already. So dyskinetic, dystonic, chorioathetoid, ataxic, and non-classifiable cerebral palsy. So that gives us a base to work upon. Now the problem with cerebral palsy is 1 in 3 cannot walk, 1 in 4 cannot talk, 1 in 4 has epilepsy, 1 in 25 are deaf, 1 in 2 have intellectual disability, 1 in 4 have behavioral disability, and 1 in 4 have bladder control problems. So, and the problem with cerebral palsy is that we cannot have an umbrella description of the symptoms. Each and every child is different. They have different problems. Some will have only motor problems. Some will have motor problem with behavioral issues. Some will have squint with motor problem with behavioral issue and epilepsy. So the problem with cerebral palsy is challenging. You cannot have a generalized treatment program. Now, when you see any disease, in particular cerebral palsy, as I said earlier, it's a permanent non-progressive brain disorder. So if it's a non-progressive but a permanent, then what are we doing? If it's a permanent damage, what good you are going to do? It's a permanent disorder. That is the part of the definition. So we have to see how much change is happening. And you cannot improve if you cannot measure. है ना, एग्जाम में नंबर होंगे ना, 50 में से 20 नंबर आया तो नेक्स्ट टाइम मेरे को 25 लाने हैं, अब की बार 25 आए तो मुझे अगली बार 30 लाने हैं. So you cannot improve if you cannot measure. So the moment you see a patient, we have to measure. And one of the measure is
the gross motor functional classification. This is extended and revised that we use in our hospital, and the moment we see a patient, we categorize him according to the GMFC. This is just a broad thing. Walking without limitation is level 1, level 2 walks with limitation, level 3 walks using a handheld mobility device, level 4 self-mobility with limitation, may use powered mobility, or level 5 is transport in a manual wheelchair, is completely dependent. Now if we see these charts, the white, the top one is GMFC as level 1, the little grey is 2, more greyish is 3, more darker is 4, and the black one is for 5. So if we see different sets of the broad classification that we talked about, like hemiplegia, diplegia, tetraplegia, dyskinetic and ataxia. Okay. So now if you see here, hemiplegics, almost 60-70% of them will be in level 1. So that means they will be walking. Okay. Then diplegia, a small percentage around 20 will be in level 1. Then again broad will be in level 2. Then level 3 and level 4. And tetraplegics, it's almost black. So level 5, level 4 GMFCS level. So here we can actually see most of them, most of hemiplegics will walk, most of the tetraplegics will not walk. Now, this is a matrix for diagnosis of cerebral palsy, where you have a standard physical examination, radiology, then we have a medical record, then we do a functional evaluation on GMFCS and FMS, that is FMS, that is GMFCS, I think. I have done both are FMS, that is basically FMS, both of them are FMS. And the gait pattern, we have to actually do a gait pattern. The instrumented gait analysis that we really talk about is very, very, very difficult to run. And that costs 2 crores. And probably there is one person out of 2 crore who can actually understand what is happening. So even though we talk about it, it's very difficult to work. And then if we spend so much of money and time, what are we going to get out of it? And I'll show you how we do it. Okay. Whatever my previous speaker has told, we do 90% of the things. So everything what he has told, we are doing everything. The other thing that is important for us is communication. अब वो बच्चा आ गया है, आपने कहा ऑपरेशन कर दो, अब आप उसके क्या करेंगे? He is deaf. How will you do physical therapy for him? है ना? Physical therapy का मतलब क्या हुआ? टांग ऊंची नीचे पकड़े करना? No, it is not. You have to make him learn. So how you will make him learn if the child is deaf? So now I have to think about it. कि भाई इसका ऑपरेशन करना है क्या? करके करेंगे क्या? Recurrence हो जाएगा. That is why it becomes important for us. GMFCS level, then communication, what we call as CFCS classification. And my young colleagues are with me, and I have all these skills right on my table. They are spread on my consultation table. Then we also do EDAX. 95% of the time, the primary care physician misses them. Patient is very thin, hyposthenic, बिल्कुल हड्डियाँ निकल रही हैं. You have to suspect कुछ ना कुछ गड़बड़ है. And then as soon as you ask, अरे भाई क्या हो गया? ऐसा बच्चे को बार-बार दिखाने ले जाना पड़ता है खांसी जुकाम के लिए. खांसी रहती है. That खांसी is because of this. Because the child is aspirating every day. Every time he is fed. Okay, so we have to identify that. EDAX. Then those kids who are able to make few steps or walk, we do a diagnosis. He was part of our team. Ashish was. So he knows what we do. Okay. So there are few caveats. Okay. Before we proceed, there are few caveats. That it's a static encephalopathy, but the musculoskeletal issues are progressive. है ना? Musculoskeletal, why? Because the muscles don't grow as good as the bone grows. है ना? तो क्या होता है? धनुष हो जाता है. The bone growth is happening. The hamstring is not really growing as fast as the That is why we call this a short muscle disease sometimes. है ना? तो धनुष कैसे होता है? धनुष यूँ हो जाता है धीरे धीरे. You have flexural deformities, है ना? Then these muscle tendinoids are smaller. The muscle tendinoids have reduced physiological cross-sectional area. They have altered fascicle length and pennation angle. Most of them are two joint, but some one joint muscle can also really get affected, because it's a misconception that only two joint muscles are going to get affected. The range that we do is basically approximation. Then we have to apply stretch while eliciting minimal or no muscle activation, because that's how we are doing. We're trying to stretch out. अरे भाई कितना tight है? कितना tight कैसे? It's a passive thing. There is no active muscle activation happening. Quadriceps तो काम ही नहीं कर रही. आप तो खींच के देख रहे हैं. अरे भाई टांग सीधी करो. Hamstring कितनी tight है? अरे तो quadriceps ही तो काम करेगी. But we unfortunately not able to do practically. Then, as soon as we do a physical evaluation, the important thing is to do evaluation under anesthesia also. है ना? Because then and only then you will be able to know that it is contracture or it is spasticity. Because if it is spasticity, as soon as I give a general anesthesia, the legs will become straight. And the child doesn't need to do anything except doing a physical therapy. There is no intervention is required. है ना? So things become different. So we have to evaluation. And we should have a systemic practical routine. Unless we have a fixed routine, we will always forget what points we should look into. Then we look into strength. Selective motor control is very, very, very important. If you operate in a child with a poor voluntary control, it's going to recur, your surgery is going to fail, everything is going to fail. That is an important issue. Then degree of static muscle and joint contracture, torsional bone deformities. One is rotation. Rotation means that my leg, whole of my leg turns. So whole of the femur turns, that is rotational deformity. Other is torsional deformity, when the femur actually rotates on its own axis. Okay, so that derotation osteotomy is not done for hip migration, so I'll correct that. It is basically done for derotation, V-shaped derotation osteotomy for torsional deformities of the long bones. Okay, then we have fixed and mobile foot deformities, the balance, equilibrium, response, standing posture, gait by observation. Observational gait, I strongly believe, is as good as instrumented gait analysis if you have good eyes. And the problem is, I see what mind knows. So if your mind doesn't know, even instrumented gait analysis will not help you. Okay, and it takes time. जो ये आपकी बिल्डिंग बना रहे हैं राजमिस्त्री, उनके पास क्या है? उसको क्या बोलते हैं? वो एक नीचे एक मेटल का लटक रहा होता है डोरी के साथ, गुनिया नहीं, गुनिया, और एक वो एल्यूमिनियम का फट्टा, और इतनी बड़ी बिल्डिंग तैयार हो गई. Just by experience, good observation and knowledge, that can make such a big building. So you don't need a 3D printer to make a Mahatma Gandhi University. Okay, so these are different tests that are being done, and please stop me when the time is over, because Sonu has given me a whole book, interventions. He has not given me a single thing like botulinum or surgery or interventions. Alright. And we measure spasticity by modified Ashworth, everybody knows it. Okay, and I think Sonu's thesis was on modified Ashworth spasticity with H reflex. And he will tell you that it is just a proxy measure. It really doesn't give you a true picture of spasticity. Then selective motor control 0, 1 and 2. Okay, 0 is only pattern movement. 1 is partially isolated. Say if I tell him to do dorsiflexion, and then he will dorsiflex, and then he will also extend the knee, and so there is poor selectivity. That is 1. And 2 is like complete isolated. Only that particular muscle is. This is important. Okay. So because if I want to inject each and every botulinum toxin in each and every spastic muscle, then I will need 1 kilo of botulinum toxin. है ना, 1.5 किलो में तो पूरी धरती को खत्म किया जा सकता है botulinum toxins, है ना. I have to be very selective. What is the pattern? What is the key muscle? Where I should inject? Which muscle I should cut? That is very important. Then hip displacement. The moment a CP child comes, get an X-ray done. It is very important. Again, the maximum hip migration happens in GMFCS level 4 and none in GMFCS level 1. So you will keep listening of GMFCS because this whole thing roams around that functional level, how functional you are. Okay, so this is the right way to do an X-ray, and someday we will talk about it. Now, the other good thing is that you should know is prognostic factors. Anna? There is an ABC NGO, okay, and he operates on every child. जो भी आगे बच्चा लाओ इसको अंदर फैक्ट्री काट दिया, तो उस बच्चे को एक बार प्लास्टर लगा दिया, प्लास्टर लगाने के बाद उसका नी और जो है एंकल वो सब स्टिफ हो गया, बच्चा खड़ा है, बिल्कुल स्ट्रेट हो गया, and over a period of time the range comes back and then he again becomes as he was before, है ना? So you should know to do or not to do. That is the biggest question. And as my undergraduate surgery book told me, it is not important when to do surgery, but the most important thing is when not to do surgery. So if a child cannot sit independently by 4 years, it is unlikely he or she will ever walk without assistance. Okay? So this is my observation over a period of years, and other teachers and everybody has told me. So now when I am talking to my patient and when the parents are asking me, I will tell them, देखो 5 साल का हो गया है, अभी तक खड़ा नहीं हो रहा है, अपन सब कुछ कर लें पर फिर भी ऐसा लगता है कि वॉकर ही पकड़ के चलेगा. अरे नहीं साहब, ऑपरेशन करो, चलेगा साहब, बच्चा चलेगा, नहीं चलेगा बाबा. All right. So now the hope, why you want to do intervention, that is also important. And you'll be surprised when I show you the next slide. Oh, that's not me, it's a couple of slides back. So all these things Dr. Jitendra has already told you. This is the traditional pyramidal approach: PT, OT, oral, neurologic, orthopedics, ITB, SDR. So these are the different treatment options. See, poor nourishment, low birth weight, difficult labor, okay, prolonged labor, preterm deliveries, कहाँ होती है? Rural areas, people with low resource, हैं? तो सिर्फ कह दे ठीक है भाई बच्चा तो हो जाएगा, एक बार बोटॉक्स लगाना पड़ेगा. कितना भाई? तो 300 यूनिट. How much it cost? 70,000. And the effect lasts for 4 to 6 months. So it looks very pretty, but not everybody can afford. Even the working class people, we are center of excellence for botulinum toxin. Okay? And 99% of people cannot afford. अगर अच्छे खासे मिडिल क्लास आदमी को भी कह दो कि हाँ हर 3 महीने में भैया 1 लाख रुपए लगेंगे, how many people can afford it? Okay, so we have to think about the socio-economic problems also. And there is something called as phenol block. Okay, phenol is also used as a neurolytic blocks. And we do lot of phenol. Because 50 ml की बोतल 50 रुपए की आती है ना? एक 50 रुपए की बोतल से मैं कम से कम 10 जनों को 10 ब्लॉक्स लगा सकता हूँ, कम से कम 10, 20 भी लगा सकता हूँ 50 रुपए. I will do that. बट कैसे लगाना है? सेंसरी इन्वॉल्वमेंट नहीं हो, मोटर ही होना चाहिए. दैट इज एन आर्ट. बट देन एन आर्ट इज यूज्ड इन सच अ पीपल ओनली. ओके, सो डोंट गिव सजेशंस व्हिच पीपल कैन नॉट अफोर्ड. देयर इज नो पॉइंट. नाउ इवन इफ यू डू एवरीथिंग, अरे भाई बोटॉक्स लगा दिया है, बैलेंस रिएक्शन, एट द एंड ऑफ द डे बच्चा स्कूल जा रहा है क्या? आपने सर्जरी कर दी, फिजियोथेरेपी कर दी. फिजियोथेरेपी क्या है? इट इज अ वेरी कॉस्टली थिंग. लोग घर जाते हैं 600 रुपये कम से कम देते हैं. अब सीपी तो वैसे ही रहेगा. तो 6 महीने में क्या करेंगे? कितना बिल हुआ 6 महीने का? 15,000 इंटू 6 70,000 रुपये. And by doing the stretching, the effect lasts only for half an hour. अभी 8 बजे कराइए ना एक्सरसाइज, अभी 9 बजे वो वैसा ही है जैसा पहले था, है ना? तो we should, the ultimate aim is that the child should be able to participate in community, he should be able to go to school, and he should be able to interact with the society. And the best intervention is conducive education. Yeah. Education based intervention system, what is called as conducive education. Conducive is inclusive. Special school, I am dead against of special school. Every school should be accommodative for these kids. है ना? रूल है, हर स्कूल के अंदर एक स्पेशल टीचर का होना जरूरी है ना? तो वो दैट इज द बेस्ट इंटरवेंशन. सर्जरी आपने ऑपरेशन कर पुरा दिया, ये कर दिया, थेरेपी करा दी, अब वो स्कूल तो नहीं जा रहा. सो बेसिकली वी हैव नॉट इम्प्रूव. प्रैक्टिकली दैट इज द ट्रूथ आउटकम, है ना? परंतु कई बार ऐसा भी होता है, मुझे याद है एक बच्चा था, वी ऑपरेटेड, वो स्कूल नहीं जा रहा था. वी डिड अ सिंगल इवेंट मल्टी लेवल सर्जरी, ठीक है. साल भर बाद वो आया, उसकी बुआ जो है वो टीचर थी केवी में, एंड देन शी टोल्ड कि साहब इस जो आपने ऑपरेशन करा इसका दिमाग पे भी कोई प्रभाव पड़ता है? नहीं. तो बोले पहले तो क्या 40-50 नंबर आते थे, अभी 85 के नीचे तो बात ही नहीं करता है. सो दैट डिड नॉट हैपन बिकॉज ऑफ द ऑर्थोपेडिक सर्जरी, बिकॉज नाउ द चाइल्ड वाज एबल टू गो आउट, ही वाज एबल टू इंटरैक्ट, ही वाज एबल टू अटेंड स्कूल एंड ही इम्प्रूव्ड. सो अगर इस तरह का कोई इंटरवेंशन है, यस वी शुड डू बिकॉज इट हेल्प्स, है ना? तो सिर्फ स्पास्टिसिटी या ये जो है ना, ये सब टेक्निकल टर्म्स है. अल्टीमेटली मिला क्या? Rehab is all about functions, and if your intervention doesn't give you any kind of functional gain, it's a waste of time and money. Okay, so these are the different treatment plans. So phenol और alcohol जो है, it is still popular, है ना? और ये सब जो है, जो इसमें लिखा हुआ है, phenol, alcohol, splinting, taping, physical modality, botulinum, surgery, ये सब जो है, ये PMR विभाग जो है वो सब करता है. ठीक है. Now this is the management algorithm. So I'll just skip it because I think this is important. I'll just show you. है ना? ये बच्ची है. Okay. इसके पाँव देखो आप. Even though ये क्या है कि थोड़ा सा वीडियो ऐसा है, long short video. ठीक है ना? What she has is basically equinovarus deformity. Okay? Okay? Equinovarus deformity. Okay, now this is the same child. Okay. Anyway, I'm going to show you the best results of my surgery. Okay. So the foot is corrected. Child is able to walk well. So she has now gone from GMFCS level 2 to GMFCS level 1. Okay. This is, I think, almost in 6 months or probably in a year after that surgery. She is almost good. There is a little bit of lag. अब वो हो सकता है क्योंकि आप तो क्या दुनिया वाले हो तो आपको पता पड़ जाता है नहीं कि कौन सा काम क्या हो रहा है. But otherwise she is doing fairly fine. Okay, now I will. अच्छा ये खत्म हो जाएगा तब मैं आपको एक वीडियो बता दूँगा. वीडियो इज नॉट देयर और मुझे पता नहीं मैं इसको बंद करके वहाँ कैसे जाऊँ. So I'll show you अभी. All right. So this is a very busy slide. अब बाद में बताऊँगा. ठीक है. बोटॉक्स सब बताते हैं आपको, है ना? Now बोटॉक्स जो है basically it's a reversible chemodenervation agent. है ना? So it blocks this release of acetylcholine. तो जब acetylcholine नहीं होगा तो जो एक्शन पोटेंशियल है वो मसल के पास जाएगा ही नहीं और मसल कॉन्ट्रैक्ट होगी ही नहीं. सो इट्स अ पैरालिटिक एजेंट. ओके. एंड पर ये सुनार का काम, ये लुहार का काम. सुनार इसलिए बिकॉज यू हैव टू बी वेरी स्पेसिफिक कि कौन सी मसल में लगाना है और उस मसल में ही जाना चाहिए. अगर दूसरी मसल में चला गया, जैसे अभी वो बता रहे थे ड्रूलिंग के अंदर डॉक्टर साहब जो पहले थे. सो ड्रूलिंग, वी डू लॉट ऑफ इंजेक्शन फॉर ड्रूलिंग ऑल्सो, है ना. वी डू सब मैंडिबुलर एंड पैरोटिड, अल्ट्रासाउंड गाइडेड बोटॉक्स. बट अगर गलती से वो मैसेटर में चला गया तो खाना बंद, तो 3 मुँह तो काम ही नहीं करेगा. 6 महीने की गई, है ना. छाछ रबड़ी पियो. ठीक है. सिमिलरली आपको लगाना है फ्लेक्सर पॉलिसिस लॉन्गस में, आपने ऊपर छोड़ दिया तो फ्लेक्सर डिस्टोरम प्रोफंडस में गया. आपको लगाना है एफसीयू में, एफसीयू के जस्ट नीचे है फ्लेक्सर डिस्टोरम प्रोफंडस, वहां की जगह वहां गया. और अगर ब्लड में गया तो बच्चा वेंटिलेटर. ठीक है. सो इट इज गुड, बट वी हैव टू बी वेरी प्रिसाइज. सो इवैल्यूएशन शुड बी रियली गुड. Okay, and then we should know it's a reversible process. So before we do plan E, what my teacher told me, he told me you should have a plan B before plan A. ठीक है ना. तो plan B नहीं है तो plan A execute ही मत करो. Many of you, probably none of you know, Dr. Yusin Saab was my examiner and I was Sonu's examiner. So we had 3 generations, 1, 2 and 3. Okay. So that is also interesting. Okay. So now the problem is sometimes you cannot show improvement because of the ceiling effect. Ceiling effect means that the child is already GMFCS level 2, so there is slight improvement. अब 1 से ऊपर तो कुछ हो ही नहीं सकता. अब GMFCS level 4 है, पकड़ के 2-3 कदम ले लेता है, तो अभी भी वो वही ले रहा है ना. तो कई बार ये नहीं हो पाता है. बट अगेन एज आई सेड, इफ यू आर एबल टू शो इम्प्रूवमेंट इन पार्टिसिपेशन, दैट मीन्स थिंग्स आर गुड. ये अभी मैं स्किप कर दूंगा. एक वीडियो और बताऊंगा आपको बाद में कैसे करते हैं. इसको मैं सब उड़ा रहा हूँ सब कुछ. ठीक है. ये सब इसका वीडियो बताऊंगा. अभी ये बंद कर रहा हूँ सब. ओके. दिस इज हाउ वी डू नाउअडेज. वी डू एन अल्ट्रासाउंड गाइडेड बोटॉक्स. ठीक है. वो मैंने निशान लगा रखा है, वो रेडियस है, दैट इज FPL, है ना. सो वी 100% डू अल्ट्रासाउंड गाइडेड बोटॉक्स नाउअडेज. Previously we used to do a needle EMG. Now this is what you should do. Very important slide. ठीक है. That you cannot change GMFCS. बिल्कुल किताब पे लिख लो मोटे अक्षरों में, है ना. What we have observed, we have some data, well, I'll not go into details of that. What we have observed, more than 25 years of working, that if you do an intervention before 5 years, you change GMFCS. 4 का 3 हो जाएगा, 3 का 2 हो जाएगा. बट अगर 7-8 साल के बाद किया तो ठीक है. वो पहले 2 हाथ पकड़ के चलता था, ऑपरेशन थेरेपी सब कुछ कर कुरा के वॉकर पकड़ के चल लेगा. बहुत ज़्यादा हो गया तो 2 क्रच पकड़ लेगा, बट नॉट मोर देन दैट. सो बेसिक GMFCS नेवर चेंजेस. सो व्हाट वी नीड इज एन अर्ली रेफरल. भेजो, 2 साल में भेजो. 2 साल इज अ गुड एज टू डू इंटरवेंशन. ठीक है ना. भाई 1 साल का बच्चा ही आ गया, ठीक है, कंटिन्यू फिजिकल थेरेपी, है ना. आपको लगा नहीं यार इम्प्रूव नहीं हो रहा है तो हेड होल्डिंग आई है, आगे कुछ हो ही नहीं रहा और बहुत ज़्यादा टाइट हो रही है भाई हैमस्ट्रिंग में, तो ठीक है 2 years के अंदर डू एन बोटॉक्स. ऐसे लोगों को दैट वी हैव ऑब्जर्व्ड, वी हैव चेंज GMFCS एंड दीज किड्स, because I don't agree with that slide that if you do an intervention before 5 years there is a recurrence. Recurrence only happens if there is poor compliance. अब उसको कह दिया कि भाई तेरे को ऑपरेट कर दिया तो TA स्ट्रेचिंग करते रहना, अब नहीं करेगा तो रिकरेंस तो होके ही रहेगा ना. अब डॉक्टर क्या करेगा. आप समझ मेरी बात. सो द रिकरेंस इज बिकॉज ऑफ नेग्लिजेंस, है ना. Alright, so I will skip. So we did a study of more than 100 patients and we demonstrated, this is way back in 2014, अभी भी लिखा हुआ है इसमें IUPMR कौन चेंज नहीं 2014, तो 2014 की स्टडी है where we showed that the improvement happens, GMFCS changes. The study that I showed you earlier, उसकी एवरेज जो एज थी वो 10.9 थी, आवर्स was 5.5. I think that is the difference, है ना? ये सब मैं स्किप कर रहा हूँ, ठीक है? और एक ये जो इम्पोर्टेंट स्लाइड है, ये है ग्रोथ कर्व. क्या होता है? यूजुअली क्या होता है, पेशेंट होता है वो एक कैल्शियम और एक कॉमन प्रेस्क्रिप्शन है, एक कैल्शियम सिरप, एक बी कॉम्प्लेक्स सिरप, एक न्यूरासिटैम, ऐसे 2-3 तरह की बोतल वो लेकर आता है, थैली भर के, ठीक है? तो वो कहता है साहब ये 2 साल से साहब दवाई ले रहा हूँ और काफ़ी इम्प्रूवमेंट है. ऐसा हो सकता है? अगर ऐसा ब्रेन में इम्प्रूवमेंट है तो मैं भी एक बोतल रोज पीना शुरू कर दूँगी. Doesn't happen. That is the truth of it. That happens because of this. ये जो ग्रोथ कर्व है, that is happening. अब तुम उसको दवाई दे दो, हाइपरबैरिक चेंबर में डाल दो, है ना, एक्सरसाइज करा दो. कई फिजिकल थेरेपिस्ट देखे हैं यहाँ पर वो अल्ट्रासाउंड लगाने हैं. आई डोंट नो व्हाई. अब वो क्या है, वो यहाँ पर है, इस वाले का, ठीक है? अब तुम कुछ भी करो, वो तो कर्व ऊपर जाएगा ही, किसी कोई नहीं रोक सकता उसको. So the credit is taken. It's like flu. The last physician always take the credit. क्योंकि तो 14 दिन बाद ही जाएगा वायरल फीवर, तो जिसने 12वें दिन देखा उसको क्रेडिट मिलेगा. It is similar to that. Okay? And then they later deteriorate. Usually when we see patient is around here, 7 to 30. Okay? वो जब आते हैं तब कुछ करने को बचता ही नहीं सेवा ऑपरेशन करने की, और उसके बाद भी ग्रोथ कर्व बढ़िया नहीं होने वाला है. It is going to fall, है ना? So that is important. By doing intervention, you can change this. Okay, this, which is the best period, 2 to 7. Unfortunately, you don't get referral. क्या करें? All right. So again, outcome assessment. Finally, आपने जो भी किया उसका क्या हुआ? ठीक है? You can also use Gillette. Frequently asked questions. And the last slide, and the most important, is primum non nocere. That means first do no harm. ठीक है? पहला प्रिंसिपल. दूसरा प्रिंसिपल, measure twice, cut once. अभी गलत चप्पू चल गया तो वो वापस रिवर्स नहीं होगा. ठीक है? So this last is, I'm showing you the video. This is okay. This is a boy. Way back, many years back, we operated him. Okay, now this boy is man now, just got married, and he runs mobile repair shops. Okay. This is not an adult patient because when he came to, he was already 12-13 years old. Okay? And now this is, I think it was more than some 10 months or something. Okay, single even multi-level. So, single even multi-level क्या है? एक ही बार में 7 ऑपरेशन करना है. It is, the people do it. We have been doing it for more than 10-12 years now. ठीक है? अब the important thing is the GMFCS level has not changed. He is walking better, looking better, straighter, है ना? Bilateral hand support to bilateral stick support. ठीक है ना? This is the change that has happened. And lot of physical therapy. ठीक है? We don't operate before actually doing a test drive. We always do a test drive. Patient आता है ना, तो इतना साफ नहीं दिख रहा है, but I don't know अगर आप उसको appreciate कर रहे हैं, उसके thumb को देखना है आपको, है ना? So we have a needle there, and then if you can see that thumb is, ठीक है? मुझे लाइट लग रही है इसलिए देख नहीं रहा, वो दिख रहा होगा, देखा? है ना? So this is an EMG guided Botox. तो बस वो FPL ही हिलना चाहिए. Okay, but now we don't do this, we do 100% ultrasound. So, sorry for taking that extra time, but the thing is, doing intervention, so what we do is कि patient आ गया, उसको देख लिया, assess कर लिया, अब उसको कहे भाई अब तो भी exercise जो बताएंगे वो करना है और फिर महीने भर बाद आना, ठीक है? महीने भर बाद नहीं आया, प्रॉब्लम ही खत्म। जबकि ऑपरेट करते तो फिर नहीं आता, दिक्कत हो जाती, ठीक है? फिर आपने देखा भी करता है कि ढंग से कसरत कर रहा है क्या? हाँ कर रहा है, चेक करा ली, अब बात दोबारा आ भी गया, है ना? So that means patient has a compliance. अब उसको हाथ लगाएं, मतलब that is how we do it, ठीक है ना? And when we admit, he also knows that we admit with a contract, not CP, anybody, brain injury or spine or whatever, 6 हफ्ते एडमिट रहना पड़ेगा, 6 हफ्ते से कम don't get admitted, कोई पर्पस नहीं है ना, टाइम खराब हो रहा है सबका, है ना? So we should have a plan. Thank you.
Thank you very much, Dr. Joshi, for such a wonderful, illustrious talk. We will move on to the rest of the program. Let me set the computer for the next speaker. We'll be having Mr. Shashank Shekhar, Professor of Orthotics from Arogya Rehab Center. Good afternoon, everybody.
I am Shashank. I am done my graduation in prosthetics and orthotics from All India Institute of Physical Medicine and Rehabilitation. Currently working with Arogya Rehab Center, Jaipur. And my topic is role of orthotics in the cerebral palsy. I am just skipping these slides because Sir has already elaborated all the things. So I am just directly coming on my. I just want to say problems regularly seen with the children with the cerebral palsy are muscles weakness, abnormal muscle tone, balance problems, loss of selective control, loss of sensations, sometimes swelling difficulty, contractures and deformities, epilepsy, visual problems, hearing loss. These are some of the symptoms we regularly see with the cerebral palsy patients. And what are the primary indicators are that when does the child reach developmental milestones and growth chart standards for height and weight? How do the child reflexes react? Does it seem as if the child is able to focus on and hear his own caregivers? Does posture movement seem abnormal? Now we come on the treatment part. Treatment depends upon the severity of the deformity and the contracture. Long-term treatment includes physical and other therapies, sometimes knee surgery and sometimes with the bracings also. What is the orthotic criteria in CP? Patient depends upon the age of the children, types of the CP and severity of the deformity, mental audio visual capacity of the patient, expectation of the family, because basic thing is that the patient family didn't want, चाहते नहीं है कि वो ब्रेसिंग यूज करे पहले, क्योंकि उनको फैमिली में भी ये दिखना नहीं चाहिए कि वो कुछ ब्रेस यूज कर रहे हैं, ये सब चीज़ बहुत बड़ी बात होती है। एंड द ऑब्जेक्टिव्स ऑफ ऑर्थोसिस इन सीपी आर का टू कंट्रोल द इनवॉलंटरी मूवमेंट्स, टू असिस्ट डिजायर मूवमेंट्स, to prevent deformities and to correct deformities and to improve the basic thing is the gait pattern of the patient. We talk about the common deformities in the first we will talk about the upper extremity. In the upper extremities, in the shoulder there is adductor tightness, internal rotator and flexor tightness. In elbow there is a flexion contracture, in forearm pronator tightness, wrist and hand flexor tightness, and thumb adductor tightness, that is called thumb in palm deformity. For this, to correct the hand deformity, we use generally the WHO, that is not wrist hand orthotics. Its basic function is to for the hand positioning, thumb in palm deformity, to control the thumb in palm deformity, and to prevent the wrist flexor flexion contracture, and it can assist in motor control function. Now we talk about the lower extremities. In lower extremities, in hip there is a adductor tightness and adductor femoris tightness. In knee there is a flexion contracture. In ankle, equinus or tear tightness, and in foot, proper bottom valgoid foot deformity. Basically, in lower extremity, we see two types of deformity. One is externally rotated deformities, and the other is internally rotated deformities. In externally rotated deformity, there is a femur externally rotated, knee is hyperextended, tibia externally rotated, heel or calcaneus goes into varus, foot is supinated, and forefoot is adducted. In IRD, there is a femur internally rotated, knee flexed and goes into the valgus position, tibia is internally rotated, heel or calcaneus goes in valgus, foot is pronated, and forefoot is abducted. These are the basic deformities we see in the. These are the some gait deformity in CP: toe walking gait, crouch gait, seizuring gait, and stiff knee gait. Now come to the orthotic management. The orthotic management treatment goal, as per the International Society for the Prosthetic and Orthotics, is to correct and to prevent the deformity, to provide a base of support, to facilitate training in skills, and to improve the efficacy of gait. All the lower limb orthotics have two types of categories of the orthotics. One is functional orthotics and second is the accommodative orthotics. In functional, orthotics is designed to support abnormal biomechanics, correct the various foot deformity, and support the functions. While the accommodative orthotics generally consisted over the counter braces, splints, cast, knife bars, heel arch supports that are used generally for the public to relieve the pain, relieve sensitive areas, reduce pressure, redistribute weight, and address minor foot problems. These are the several types of foot orthotics: foot orthotics, ankle foot orthotics, hip knee ankle foot orthotics, knee orthotics, spinal orthotics, trunk hip knee ankle foot orthotics, and prophylactic braces. Now come to the foot deformity. In the foot deformity, there are mainly equinus deformity, hallux valgus, equinoplanovalgus foot, or equinocavovalgus foot. These are the basic deformity we see in the foot of the CP child. Main purpose of foot orthosis for the correction of the foot is to stabilize the subtalar joint without restricting the ankle movement and prevent the unwanted ankle movement, assist in preferable ankle movement, give limited control of knee motion. For this, we can give UCBL inserts or SMOs. These are the different types of foot support. This is SMOs, UCBL support, DFOs. Now, I'm just saying the SMO is giving. SMOs are given for the correction of dynamic equinus, varus valgus foot, and types of CP, hypotonic and ataxic CP, we can provide it. And the UCBL is for the mid and mid foot instability, and while DFO is for the equinus stability, we can provide it. Now come on the ankle foot orthosis. What is the main function of the ankle foot orthosis? Is to assist dorsiflexion and reduces foot slabs, prevent the unwanted ankle motion, and to permit gradual positioning of ankle. There are two types of AFOs. One is solid and the other is articulated. In solid AFO is given for the provide better ankle stability and better control at the knee. Main problem is the basic problem of solid AFO is that breakage, while the articulated AFO it permits some limited motion to the ankle. That's why it is better than the solid. But in some cases we can't give the articulated also if there is more tightness and other things. This is the spinal orthotics. It is basically designed to absorb and use the torques that are in normal walking. It has limited stability at the ankle and the subtalar joint. It is basically made up of carbon fiber. So carbon fiber provides dorsiflexion assist and allows limited plantar flexion in this. This is the flow reaction orthosis. The main principle of the flow reaction orthosis is to control the tendency of knee flexion by shifting weight line anterior to the knee joint. It is the main function, and it encourages knee extension. Basically in crouch gait we can provide this type of FROs, but the indications for this are poor quadriceps and where there is a knee instability we can provide. In the FROs, the basically design consists of posterior solid having ankle in 3 to 5 degrees of plantar flexion. We provide 3 to 5 degrees in plantar flexion, and anterior cell or pre-tibial cell which covers patella also. It also controls the hyperextension. When we heel strike, it controls the hyperextension. During the foot flat, it is ground reaction to stabilize weak knee, and the ankle and it also controls the mediolateral stability and rotation control of the ankle, and knee flexion. It promotes the knee rotation, knee flexion control also, which helps in that. But there is a disadvantage of this also. We can't give this if there is a bilateral crowd or bilateral. We can't give this very FRO, because in the main disadvantage is when the patient is walking with this, you will notice that patient अपने heel उठा करके ही चलते हैं. उस समय पेशेंट के मतलब जो पेशेंट का गेट आप उतना अच्छा नहीं दे पाओगे. तो ऑलवेज वी कैन प्रोवाइड दिस इन इफ देयर इज ए यूनिलैटरल दैट वी कैन प्रोवाइड. These are the positioning device for the night splinting to prevent the contracture during growth. Spurt muscle does not elongate with the skeletal growth and may cause deformities. Night bracing is required to prevent deformity when muscles are not in use, usually accompanied by exercise program in a day. Other orthoses used in CP for this are foam abductor pillow for the keeping his legs in the abduction. It has hook and loop strap used for keeping hip in abduction. Inexpensive and used to replace, given for small child to maintain hip in abduction. This is a hand single collar. For those patients who have not good leg support control, for that there is a good head support. Foam collar around jaw and occiput improves breathing and eating swallowing social interaction. This is the Swas orthosis. Basically, it is for the standing, walking, and control the sitting hip orthosis. This allows wearer for sitting, standing, and crawling, or walking while keeping the hip in abduction. It also helps in providing sitting balance and prevents seizuring also while ambulation. But it is contraindicated for hip dislocation greater than 20 degrees. If there is a 20 degree hip dislocation, we can't give that Swas orthosis. These are some of the Theratops lycra garment. Basically for the CP and MMC we are using, and it provides dynamic springes to control abnormal tone of the body, stabilize posture and improve function. And this is the standing frame orthosis used. It is basically used for the patient below up to the 18 months to the 4 years of the child to provide the hip abduction and internal rotation of the hip. Knee ankle foot orthosis, correction and accommodation of knee ankle and foot deformities. Careful with knee joint with lock can be used as a walking device But in CP cases, we can't use these things in the child region. Spinal deformity. For the spinal deformity, we use scoliosis, commonly seen in children with cerebral palsy, corrected by thoracolumbar spinal orthosis. It is basically given for the positional purpose, not for the and to slow the progression of the deformity. We use some assistive devices for the, as I have shown that GFMC level 5. So these are the assistive devices which we use. Thank you.
Good afternoon, everyone. Myself, Dr. Kriti. I am from Physiotherapy College and pursuing my PG in Neurosciences under the guidance of Dr. Anjali Jain ma'am. Now the physiotherapeutic management, basically we have divided physiotherapeutic management in 4 different categories. First will be the infancy, then preschool period, then period during the school, when child is in the school, and then to the adulthood. Now the main aims and objectives of the physiotherapeutic management, those will be family education. Here family education plays the most important role in the treatment. Handling and care, promote infant and parent interaction, encourage development of functional skills and play, promote sensory motor development, establish head and neck control, and attain and maintain the upright position. Now the family education. Educate families about the CP. Generally families don't know about the CP. Provide support in their acceptance of the child. Goal setting and programming should be done with family. Be realistic about the prognosis and efficacy of the physiotherapy while remaining hopeful. Listening to parental concerns and recognizing personal values and strengths. Here we have to know what are the complaints by proper assessment of the family. Now handling and care. Promote parents' ease, skill and confidence in handling child. Positioning, feeding, caring techniques should be taught. Promote symmetry, limit abnormal posturing and facilitate functional motor activity. Use variety of movements and posture to promote sensory function. Use positions to improve functional voluntary movement of the limbs. These are the aims. Mother and child relationship. All the activities and all the tasks which we are giving to the child should be done on the mother's lap, close to the body and face, so that her touch, stroking and talking to the child may help in the motor development, but also the body image, and a child will also get confidence. Weaning of child to a physiotherapist should be carefully done after mother-child bonding. Now we can't introduce more than one therapist or developmental workers. It may be disconcentrating for the child and even to the parents also. Not to overload with exercises, but rather use corrective movements and postures within the ADL of the child. Now here we use colorful task things, pegboards. Those will be the those will be used to correct movements. Otherwise, it will be overloading for the child. Now, feeding and respiration. Here we have to counsel the mother. Position in a propped up sitting for feeding, for greater hip stability and symmetry during feeding position in a high chair with adaptation. Head and neck position should be in neutral rotation and slight flexion to facilitate swallowing. Otherwise, mother will gain problems. Deep respiration can be facilitated before feeding by applying pressure on either thorax or on the abdominal area. Now, to facilitate sensory motor development, reaching, rolling, sitting, crawling, transitional movements like standing and pre-walking are facilitated here. Few equipments we can use, for example, the adapted chairs. Do not give too many stimuli at once. We should always give time to the child to experience the tactile stimuli. Now, to improve proprioceptive and vestibular function, they are compensatory stimuli for visual impairment and also develop body image. Now, touch, pressure, resistance, these are the part of proprioceptive and vestibular functions. So, touch, pressure and resistance can be correctly given to stimulate movement, giving clues as direction and muscle action. Here we use various approaches like PNF. Do not give any treatment or other proprioceptive stimuli from behind, as this will be creating extensor thirst. Now, visual development. It can be easily integrated with methods for head control, hand function, balance and locomotor activities. One may have to accept unusual head positions and other patterns which make it possible for the child to use residual vision. Here again we use his or her favorite toys to facilitate visual functions. Now, the language development. We can't use more complex words. Here we have to use simple and easy words with appropriate examples. Delay is normal for a child who cannot yet understand meaning of sound and words and conversation. Here we can tell or command child to flex his hand. We have to use normal words. Now, maintaining an upright position. Here we can use adapted chairs, standing frames, parallel bars we can use. Use of orthosis can be delayed until some voluntary movement is gained. Now, we can use Swiss balls, vestibular boards, pack boards. Now, the second criteria which is preschool period. The main aim is to reduce the primary impairment and to prevent the secondary impairments which can cause due to primary impairments. Now, to increase force generation, that is strengthening, creating demands in both concentric and eccentric work. If a child has some voluntary control in a muscle group, capacity for strengthening exists. अगर voluntary control बिल्कुल ही नहीं है तो strengthening होएगी नहीं, और अगर है तो there are chances. Use of electrical stimulation or by strengthening within synergistic movement patterns. Now, to participate in strength training program, child must be able to comprehend and consistently produce a maximal or near maximal efforts. Now, to reduce spasticity, positioning and anti-synergistic patterns. Now, if a patient or the child is hemiplegic, तो position ऐसी रहती है, hand की flexion deformity में चला जाता है, तो हमें anti-synergistic pattern के अंदर उसको रखना होता है. Now, stretching of tight structures, MFR, range of motion exercises, rhythmic rotations and splinting and serial casting can be done. Increase mobility and flexibility. For that we can use range of motion exercises, maintain length of muscle by regular stretching and splinting, strengthening exercises for prime movers of the joint. To prevent deformity, serial casting techniques, orthosis, night sprints, lycra sprinting, taping techniques, we can use these. Again, to put the hand or the limb which is in synergistic pattern, तो हम ये use करेंगे तो anti-synergistic उसमें रखेंगे. Improve physical activity. Exercise should be intensive, challenging and meaningful and improve integration of skill into function. Movement should be goal-oriented and interesting to maintain motivation. Again, same thing, we can't use complex tasks. Here we have to use simple tasks so that हम child को बोलेंगे कि kick a soccer ball और pack boards को बोलेंगे, pack boards पे बोलेंगे कि red color का आप सारे pack boards में से निकाल लीजिए, ऐसा हमें करना है. Now, feedback is important. CIMT also improves function in hemiplegic patients. CIMT is constraint-induced movement therapy. Oromotor rehabilitation should also be provided here. ambulatory techniques. For ambulatory techniques, we will be using weight bearing. Before ambulatory techniques, we have to use weight bearing exercises, pre-gait training जिसको बोलते हैं, वॉकर्स एंड क्रचेस. अगर वॉकर पे भी हमें चलना है तो उसकी पहले प्री-गेट ट्रेनिंग तो करनी ही होगी हमें. Treadmill training, adapted tricycle, wheelchair and motorized wheelchair. Motorized wheelchair, these are the modified wheelchairs. Now to improve play. Play is the primary productive activity of children. It should be motivating and pleasurable. Motivate social skills, perception, conceptual, intellectual and language skills. Now appropriate toys and play methods should be suggested. Again, those fascinating toys we can use for the child. Parents should encourage to let children enjoy their typical play activities. Now the third criteria, which is school age and adolescence. To improve activity and mobility and endurance, here gait training can be continued throughout the school age. Gait training can be done on the parallel bars with the biofeedback mirror in front of that. Architectural modifications may be required. अब हम लोग चाइल्ड को भेज रहे हैं स्कूल में तो हमेशा स्पेशल स्कूल्स में नहीं भेज सकते, वो काफ़ी एक्सपेंसिव होते हैं. तो उनको नॉर्मल स्कूल्स में भेजने के लिए भी वहाँ पे आर्किटेक्चरल बैरियर्स रहते हैं. कहीं पे लिफ्ट नहीं होगी, कहीं पे स्टेयर्स नहीं होगी, तो उसके लिए वी हैव टू यूज रैम्प्स, रेल्स. Orthotics increases energy expenditure. Regular exercises, proper diet, nutrition and participation in recreational activities should be encouraged. School and community participation. Positioning, lifting, transfer techniques should be taught to the school personnel. Opportunities should be given to participate in community and recreational activities. Now, we should allow the child to participate in the recreational and other functions and whatever is planning in the school. Adapted games and athletic competitions and team participation improves self-esteem. It only improves self-esteem, confidence of the child to cope up in the community. Introduce child to community fitness programs. Now the last one is transition to adulthood. Improve functional skills. Maintain and improve cardiovascular fitness, weight control, maintain integrity of the joint, muscle, help prevent osteoporosis. Now जब वो adulthood में आ गया है तो हमें secondary impairments जो है उन पे main focus करना है. तो we have to introduce him or her to the fitness clubs, swimming, wheelchair aerobics, adapted sports. Disability certificates and compensation should be provided to reimburse handicap facilities. Introduce him or her to helpline numbers and community care centers. Now, some photographs like here the child is, we are using vestibular balls or Swiss balls with the mirror feedback or biofeedback, we can call that. Now the Swiss ball, strengthening exercises are done here with the bridging and bridging is done here. Reach out activities. Here the upright position is given through this supporting pillow, walker. This is basically Bobart's activities in which we are using only functional movements using different tasks. This is wobble board. In this balance and coordination will be done. Now few approaches which we can use, like Roots approach. In this basically two techniques are used, inhibitory techniques and facilitatory techniques. So the principles of the Roots approach: controlled use of sensory stimulus, use of ontogenic development sequences from lower to higher level, use of activity to demand a purposeful response, practice of sensory motor response is necessary for learning. These are the principles. Now there are two techniques. First will be for facilitation and other will be for inhibitory. So for facilitation, quick icing, quick brushing, tapping, hacking, and rapid movements are done. Rapid movements are done in the flaccid stage. Inhibitory technique, prolonged icing, prolonged weight bearing, painful stimuli, these are done in the spastic stage. Now here is the video representation of Roots approach.
For light moving touch technique, all you need to have is your fingertips, or you can also use
They are giving just slight touch.
the selection of your movement will depend upon which muscle you want to activate.
Now the other one is Boba's approach. Principles for this are encouragement of normal movement pattern, focusing on quality of movement, the normalization of tone to facilitate active movement, positioning and posture in line, sitting and standing, discouragement of compensatory movement, those are the trick movements, promotion of maximum functional recovery. Here we are focusing basically on the normal motor movements. इसके अलावा कुछ भी complex movements we are not using. Task related exercises can be done on the Swiss ball.
Thank you, Prati. Now, I request Dr. Sushmita Ahirwal, Assistant Professor from Occupational Therapy.
Good afternoon, everyone. Today I am presenting occupational therapy in cerebral palsy. So, already you know about cerebral palsy. Yes. So I am skip this slide. So classification of CP is spastic, dyskinetic, ataxic, and mixed. Spastic is diplegic, quadriplegic, hemiplegic, double hemiplegic, dyskinetics, choreorthotoid, dystonic, and orthotoid. So what is occupational therapy cerebral palsy evaluation? So evaluation and assessment is we are taking clinical observation, interviews with child and family, and assessment tool. The occupational therapist assesses each individual child abilities and needs. Together they evaluate areas of performance, client factors, activity demands, and context. The occupational therapist may use one or several instruments, that is standardized test requiring specialized administration and interpretation skills, and can provide the team with specific information about reflex development, sensory motor functioning, motor skills, and developmental skills level. So perform of occupational therapy evaluation is demographic data, history. You already know about prenatal, how to take history about cerebral palsy. There is prenatal, perinatal, and postnatal. Family history, developmental history, reflex maturation, spinal level, brainstem level, midbrain level, cortical level. So clinical examination are higher motor functions, motor systems such as muscle tone, deep tendon reflexes, voluntary motor control, hand function test, DAN test, that is active digit extension with the wrist in neutral, and S test, that is active composite extension. Active digit extension is individual muscle test, that is flexion extension, and for active composite extension is composite action of hand. This is the sequence of active composite extension. Then you already know tightness, how to evaluate TCD, involuntary movement, coordination test, sensory examination, gait, spatial assessment test, functional evaluation, writing assessment, cognitive perceptual evaluation, vocational evaluation, and home evaluation. So there are various assessment tools and standardized assessment scales. For example, Alberta infant motor scales, assessment of process scale, Bayley scale of infant development, coping inventory, Denver developmental screening test, evaluation tool of children's handwriting, gross motor function measure, Hawaii in early learning profile, Miller assessment for preschool, Peabody developmental motor scale, pediatric interest checklist, pediatric volitional questionnaires, school function test, VFIM, toddler and infant motor evaluation. These are the very expensive tests. So most of the I am explaining most of the tests. First is AHA. AHA is assisting hand assessment. So in this test, they evaluate assisting hand in bilateral use activities. You have to evaluate bilateral hand function activity. So age range is 18 months to 12 years, and this is a paid scale. So you have to purchase this. Then next is PADI. PADI is a behavioral checklist, and purpose of this assessment is examine functional capabilities and typical performance to detect function delay, track process after intervention and assess intervention outcome. So this is also paid assessment tools. So it takes 20 to 16 minutes depending on therapist experience. And next is GMFC. You already know about GMFC score. Next is COPM. COPM is self-perception of identified occupational performance. It takes 30 to 40 minutes, and it is also paid, and age range is 7 years and above. GAS is goal attainment scale. It evaluates self-identified patient goal and measurement of criteria. This is a patient reported outcome scale. So this is free. It is available in internet. You can go through this. Okay. So next is MACS. MACS is Manual Ability Classification Test. This is a family patient caregiver report questionnaire. It has basically questions, various questions. So you have to ask this question to the patient and parents. And age range is 4 to 18 years. And this is a free. It has free checklist and chart. Then MUUL is Melbourne Assessment Unilateral Upper Limb Function. QUEST, QUEST, Quality of Upper Extremity Skill Test. It requires 45 minutes, and it assesses quality of upper extremity movement and associated with grasp, weight bearing, protective extension and dissociated movement. Next is Jepsen-Taylor hand function test. It basically assesses hand function activities, and as age range is 5-year-old and older. Administration time is 15 to 20 minutes, and it is also paid. So you already know about GMFFC, level 1, level 2, level 3, level 4 and level 5. So basically occupational therapy intervention. Individuals with CP who receive OT services can experience a sense of empowerment and control when they successfully perform meaningful occupation within the self-care, instrumental, ADL, activities of daily living, sleep, rest, work, education and leisure domains. So OT practitioner develop and implement intervention to promote functional performance, skills and individual capacity. So what are the intervention strategies? There are various intervention strategies we are following in our department. First is neuromuscular re-education, that is roots, Bobar and sensory re-education and sensory integration. So hand function training, hand function activities, pegboard activities, and I am also talking about habit training. Next slide. Sprinting, hand splinting, functional splinting, resting pen splint, and wrist cock-up splint. ADL training, it has self-care activities and dressing activities, many more. Self-help devices, assisted devices such as dressing sticks, universal curls, spoon feeding devices, handwriting devices such as Vanchik writer, and mobility aids such as wheelchair, crutches, cane, walker, Oromotor activity, oromotor therapy include massages of the oral motor area and cheeks, bones, and vibration to the muscles, and outer area of mouth and cheeks, tapping and vibration brush. And cognitive perception training, in next slide I am talking about cognitive perception training, free writing skill, free vocational training, and environmental modification. So basically I am focusing in more in contemporary approaches, that is new approaches. So you already know about traditional approaches, that is roots approach, NDT, range of motion exercises, conference induced movement therapy, that is CIMT, and splint. And contemporary approach include collaborative learning approach, habit, COOP, robotics, and virtual reality technology. So range of motion exercises such as active range of motion, passive range of motion, resistant motion, followed according to the child's capability. Then roots approach, it was developed in 1930s, and key components of root approach are sensory stimulation to evoke a motor response and use of developmental posture, that is ontogenic motor patterns. So goals of root approach is to normalize muscle tone, evaluate developmentally, and treat a sequential manner. Movement is directed toward functional goal. Repetition is very important in roots approach in therapy. The repetition is necessary for the re-education of muscular responses. Ontogenic motor pattern. These are the pictures of ontogenic motor pattern. That is total flexion, rollover, pivot prone, co-contraction, on elbows or four, standing upright, walking. Roots also describe facilitation technique, that is cutaneous and proprioceptive. Cutaneous include light moving touch, fast brushing and icing. Proprioceptive include heavy joint compression, stretch, resistance, tapping, vestibular stimulation, inversion, vibration, and osteopressure. Inhibition technique mainly used in hypotonicity, that is spasticity. So we will give a gentle shaking or rocking, slow rolling, light joint compression, tendinous pressure, maintain stretch, and rocking in developmental pattern. So for roots approach there is a research. This paper comprises a brief explanation of the roots approach and its scientific reconciliation with available literature, which shows that many of the basic concepts are still valid. Okay, you are using right now, और तुम अभी भी यूज करते हैं ये सारी चीजें, है ना. रूट्स अप्रोच हमने छोड़ा नहीं है. So basic concepts are still valid and viable within current neuroscientific thinking. So next is Bobard approach. This is also, you know, so key elements in NDT are facilitation using sensory input to improve motor performance, management of compensatory motor behavior, and an overall management strategies. And constant induced movement therapy, CIMT. CIMT basically developed in 1993. CIMT involved placing a constraint on child less impaired upper limb. Basically we are using in upper extremity activities. So you have to use only one hand, that is involved hand. So effect of CIMT is explained as cortical reorganization, dendrite branching, and synaptic strength. So there is a video of CIMT. So what is this case? Hemiplegia, infantile hemiplegia, and child is using his involved hand, and on involved hand there is a देयर इज क्लॉथ वगैरह कुछ भी यूज कर सकते हैं. सो दिस इज अ CIMT टेक्निक. So next is contemporary approach, that is new approaches. So first is collaborative learning approach. This collaborative learning approach is a creative learning process not only for child and his parent but also for any therapist. So you have to involve parents, caregivers and the siblings. So basically collaborative learning approach is parents के साथ, siblings, caregiver के साथ you have to give therapy. So a child and his parents are offered opportunities to discover what they want to achieve and what is needed for this achievement, to recognize what they already know and can do, participation in evaluation of progress. So Bell and Simpson found in their many studies that parents and families want the following, that is education and information, parental training in skills to help their child and emotional support. So this is a picture of collaborative learning approach. इसमें क्या लग रहा है आपको? पेरेंट्स बच्चे के साथ इन्वॉल्व हो रहा है, ठीक है. थेरेपी हमें पेरेंट्स को भी बतानी, होम एक्सेस प्रोग्राम भी देना है ताकि चाइल्ड का डेवलपमेंट और अच्छे से हो, ठीक है. So this is a basically collaborative learning approach. Then there is a study of collaborative learning approach. The theoretical and practical training of communication partners was obtained. Means इसमें ये है कि collaborative learning approach is very important. Then hand, arm and bimanual intensive training, that is habit. Occupational therapists have traditionally used bimanual therapy for children with CP. However, no documented model of bimanual training existed until Charles and Gordon published a protocol for hand-arm bimanual intensive training in 2006. So this is a new approach. So bimanual therapy is a process of learning bimanual hand skill. You have to give bilateral hand activities. Okay. So bimanual therapy is strongly grounded in concepts from cognitive motor based theory and aims to provide the opportunity for children with CP to practice and learn bimanual skills. So किस पेशेंट में दे सकते हैं ये एक्टिविटीज हम? जिसकी दोनों हैंड एक्टिविटीज अफेक्टेड हो, हैंड फंक्शंस पुअर हो जिसके, तो हमें बायमैनुअल एक्टिविटीज देनी है. एंड हेमीप्लेजिक पेशेंट है तो भी हमें बायमैनुअल एक्टिविटीज देनी है, या CIMT. तो सबका ही रिसर्च while repetitive practice of bimanual tasks facilitate opportunity for implicit learning, we propose bimanual therapy also targeted explicit learning or procedural knowledge. Skilled bimanual performance involve perceptual and cognitive process whereby information from environment and the task is analyzed before a movement response is executed. So there is a video of habit. ये दोनों बायलैटरल हैंड एक्टिविटीज दिया है इसमें. सो कंक्लूजन, देयर इज एविडेंस ऑफ CIMT bimanual therapy. CIMT bimanual should be viewed as complementary. CIMT could be used to target unimanual actions, but bimanual therapy could be used for children to learn how to use this action for bimanual skill development. Next is cognitive orientation to daily occupation performance. This is a new approach, cognitive orientation to, this is COOP approach. COOP approach is an approach to intervention that uses the power of cognition to drive successful performance. मतलब तुम्हें cognition सही होना चाहिए थोड़ा, मतलब जिसके अंदर cognition affected है, जिस cerebral palsy में mainly cognition affected होता है, तो you have to give COOP approach. Coop approach is based on the premise that cognition plays an important role in acquisition of occupational skills, the development of occupational competency created for use with children who have occupational performance deficit. The Coop approach can be used to promote the acquisition of new skill. You have to give new skill to the child and improvement of their existing skills. In Coop intervention focuses on the use of cognitive strategies to solve performance problem and to develop occupational competency. So step Coop approach is a goal, plan, do, check. You have to make first goal बनाना पड़ेगा, then planning करनी है, then करना है, and then you have to check. So step 1 is child, तुम्हें child and parents के साथ मिलके you have to make a goal. Then you have to create a plan and carry out. Third step is carry out the plan with the child using the plan strategies to accomplish the task and then check the plan. So example हो सकता है, you have to give ADL training, dressing activities. तो फर्स्ट स्टेप्स क्या होगी, तुम्हें ये गोल बना दिया, हमें पेशेंट को शर्ट पहनाना है, तो ये हो गया गोल. देन प्लानिंग, कैसे आप पहनाओगे वो तुम्हें पेशेंट के साथ डिस्कस करना है, पेरेंट्स के साथ, एंड देन उसे पेशेंट चाइल्ड को करने का बोलना है. देन कैसे उसने चाइल्ड ने किया है, देन यू हैव टू चेक. ठीक है, दिस इज अ कूप अप्रोच. सो देयर इज अ एविडेंस ऑफ इफेक्टिवनेस ऑफ कूप अप्रोच on children with CP, a mixed design. So conclusion is Coop intervention can be helpful in improving motor skills and achieving self-identified motor-based goals in children with CP. This was published in 2017. And next is hand splint. Hand splint also you already know non-functional hand splint and functional hand splint. So functional hand splint which are designed with the primary purpose of improving outcomes in the activity and participation, and functional hand splint are therefore worn during task. ठीक है, एक्टिविटीज करते टाइम तुम्हें पहनाना है फंक्शनल हैंड स्प्लिंट को. सो फर्स्ट पिक्चर किसका लग रहा है तुम्हें, रेस्टिंग हैंड स्प्लिंट, एंड सेकेंड इज डिस्ट कॉकअप स्प्लिंट. सो while you have to go while activities. So there is a evidence of effectiveness of hand splint. So results are diminished after splinting. Splint wearing मतलब splint के पहनने के बाद रिजल्ट बहुत अच्छा मिला है. ठीक है, this was published in 2013. Then there is a lower limb orthosis, foot orthosis, ankle foot orthosis, knee orthosis, hip abduction orthosis, spinal orthosis. So robotics, next is robotic. Robot assisted therapies involve the use of robot to assist in initiation of the movement, guidance and resistance to movement as well as provide feedback. The robotic unit applies force to the more affected forearm during goal directed movement. So this is a picture of Armio. This is a robot assisted exoskeleton for upper extremity. It provides highly intensive arm rehabilitation for patients who have lack voluntary motor control. So there is a video in this. Armio में ये कंप्यूटर पे वीडियोस होती है, गेम्स होते हैं. You have to इससे इम्प्रूव होता है हैंड फंक्शन. ठीक है, the use of robotic for rehabilitation of upper extremity shows that sensory motor training with robotic device improve upper extremity functional outcome and motor outcome of the shoulder and elbow. Basically, Armio focused on shoulder and elbow. And overall, robot assisted upper extremity therapy may assist in improving motor function during inpatient period after a stroke. तो mainly Armio stroke में use करते हैं, but there is only one Armio in India for CP. So there is a evidence of CIMT with Armio. So Armio is this study provide a framework supported by evidence-based data for non-invasive treatment of children with CP. Then virtual reality technique. Virtual reality technology allows individuals to experience and interact with 3D environment. Merens and colleagues found that computerized visual environment have opened the door to an exercise environment where the intensity of practice and positive feedback can be consistently and systematically manipulated and enhanced to create the most appropriate individualized motor learning approach. Aiding computerized virtual reality to computerized motor learning activities, basically कंप्यूटर वर्चुअल रियलिटी में मोटर लर्निंग एक्टिविटीज ज़्यादा होती हैं, हैंड फंक्शन एक्टिविटीज एंड मोटर लर्निंग एक्टिविटीज, and this exercise representation allows for visual feedback also, so and guidance for the patient. Virtual reality is an innovative treatment approach that is it in infancy, but it has shown promise in improving motor function in client following a stroke and experiencing chronic hemiparesis, and it also used in CP. And there is a systemic evaluation of effect of rehabilitation, and there is a case scenario also.
Time is over.
Okay. Thank you.
Thank you for your excellent talk. Now